Life is good. Life is really good. I think they're streaming now. So
Yes.
yeah.
Good morning. Good morning. We are live streaming. Good morning, everyone. Good morning. I'm Dr. Ananya Madhyal from the Department of Oral Medicine and Radiology from ABSMIDS Memorial Institute of Dental Sciences. It gives me immense pleasure to welcome all of you to the Symposium on Orofacial pain. It's wonderful to see that so many delegates have already logged in and even more are logging in as we speak. Gautama Buddha once said that pain is inevitable, but suffering is optional. Pain is one of the most common cause for which patients seek care, and dentists are usually the first healthcare providers who are consulted for pain in the orofacial region. Most often, we see that the source of odontogenic pain usually is acute. However, the chronic pain is quite different. We need to be aware of the other sources of pain for appropriate diagnosis and for management in order to avoid unnecessary irreversible intervention. It is with this goal that the Department of Oral Medicine and Radiology has organized this symposium. We have lined up 3 interesting talks for you. We have Dr. Ruchika Sood from Mumbai and Dr. Suhas from Bangalore, both of whom are stalwarts in their field of orofacial pain. With these 2 eminent speakers, we are sure to have a very informative session today. I request Dr. Vidya Ajula, the head of the Department of Oral Medicine and Radiology, to deliver the welcome address.
A very good morning and warm greetings from the Department of Oral Medicine and Radiology, ABSMIDS Memorial Institute of Dental Sciences. Hunger, fear, and pain are a few human conditions that continue to defy a clear definition. All are sensory, cognitive, and emotional experiences that can best be described only by the sufferer. Pain associated with the disease is the important factor that affects the patient rather than the disease itself. Orofacial pain, as any other major pain, is known to have a deteriorating effect on the quality of life of affected patients. Here, I would like to quote the famous saying by William Osler: "The good physician treats the disease. The great physician treats the patient who has the disease." With this in mind, we established our own state-of-the-art orofacial pain clinic in June 2019 to provide patient counseling and pain management using both pharmacologic and physical therapy for the well-being of our patients. I'm indeed proud to state that we are well equipped with advanced equipments, including therapeutic ultrasound units, TENS units, and a low-level laser therapy unit for the management of orofacial pain. Thanks to the management of Nitte deemed to be university, the constant support of our principal and dean, Professor Dr. U.S. Krishnan Nayak, the orofacial pain clinic was inaugurated under the able leadership of our former head of department, Professor Dr. G. Subhash Babu, with Dr. Shruti Hegde as the coordinator. In today's scenario, orofacial pain is a very frequently encountered phenomenon in our population, with studies estimating a prevalence of up to 30%. It is necessary, therefore, for all dental professionals to have a clear insight about orofacial pain and its management. Here, I would now like to welcome our dynamic principal and dean, Professor Dr. U.S. Krishnan Nayak, who has been extremely supportive of all our endeavors. I welcome our vice principal, Professor Dr. Mitra N. Hegde, to the symposium. Her words of wisdom have always encouraged us. I welcome our resource persons for the day, Dr. Ruchika Sood and Dr. Suhas S., both of whom, despite their extremely busy schedules, readily consented to share their vast knowledge and experience with us all today. Finally, I welcome each and every participant of this program, and I hope it will be a wonderful learning experience for each one of us. Thank you.
Thank you, ma'am. May I now call upon our beloved Principal and Dean, Professor Dr. U.S. Krishnan Nayak, to formally inaugurate the symposium and to deliver his opening remarks.
A very good morning to all of you. Permit me to break the protocol. Let me start with our dear friend, Dr. Ruchika Sood, the guest faculty for today's program, Professor and Head of the Department, Professor Dr. Vidya, my colleague, Professor Dr. Mitra, the Vice Dean, the other faculty, another good friend of mine, Dr. Suhas from Siddhartha Dental College, all the participants. Well, I'd be failing in my duty miserably if I do not acknowledge the the efforts of Dr. Shruti Hegde, the coordinator of the pain clinic and also the coordinator of this program, for all the efforts she has put in to ensure that this program is a success. And of course, all the participants who have logged in for this program from across the globe. When I have this thing about sending every invite to almost everybody in my contact list, just to tell them that we are doing something. This is my habit, whether it is an oral medicine conference or a pain symposium like this or anything, whether it's a posterior thing, I would send it and bring an orthodontist. Obviously, I'll have a lot of orthodontists in my contact list. And believe me, to my surprise, there were so many of orthodontists and other specialists who asked me, sir, could we have the link for this thing? We would like to join. And there was a small little shortcoming. The first invitation that we had made didn't have the link in it. And then they came back and said, sir, this is the invitation with the link. So I had to repost that invitation in all my broadcast groups and personally as well. And I'm sure many of my colleagues, orthodontists, have also joined in, apart from specialists who are more connected with this. It's not that orthodontists don't need to know about pain or its management. I'm talking about people who are more closely associated with pain management, as in oral medicine, radiology, oral pathologist, endodontist, etc. I would like to thank Dr. Ruchika. I know really how busy she is, and she is a pain consultant at the NeoCare Mumbai, and it is our association goes, or acquaintance goes long while ago. Probably she reminded me it was way back in 2005 or 2006 that we first met in Mangalore itself when she was down here. And I thank her for joining in today and spending a valuable time giving us an insight into the latest about pain management. And of course, we have Dr. Suhas S. with us, who is also specially trained in pain management apart from TMJ and orofacial diseases. So Suhas, thank you very much for joining. And I am really grateful to both of you. And of course, congratulations to the entire team, Dr. Vidya and her entire team behind this team, for organizing such a lovely webinar. And of course, for the choice, not to forget about the choice of speakers, faculty for this workshop. I would, failing in my duty if I do not acknowledge the support for all these programs that we are conducting. In fact, we had one yesterday, as all of you know, the interns exit assessment, inauguration of that. So something very unique and pioneer program that we have started. And of course, day after tomorrow, we have a workshop in periodontics on magnification. So again, post-COVID, as I said yesterday also, we have really started firing on all cylinders. and I'm sure other departments will pick up the baton. They have been conducting programs, but we can go slowly, God willing and permitting, we can go physical once again with all these programs. This is my wish, but whatever said and done, congratulations, Vidya, for this program, and I wish the whole program all the very best, and I'm sure all the participants are going to go back richer in knowledge. Thank you one and all, and have a great day ahead.
Thank you, sir. It was wonderful to see that so many people were interested in the symposium. We will commence with the first talk of the day by Dr. Ruchika Sood on the topic Orofacial Pain Dentist Enigma. I request the delegates to type in your questions on the YouTube chat box, and we'll address them at the end of the session. I request Professor Dr. Subhash Babu to introduce the speaker. Over to you, sir.
Good morning to the respected principal and to vice principal and to all the delegates. Also, at this point of time, I also wish to express our sincere thanks to Dr. Ruchika Sood for having been gracious enough to agree to give a keynote address, if I can use that word, and to participate and for the dissemination of the information related to the orofacial pain. So coming to a brief introduction of the speaker, Dr. Ruchika Sood. She has been since 2 decades practicing as a dental surgeon in Mumbai, and for the past 1 decade she has been actively involved and been treating patients relating to the orofacial pain. She has undergone her diplomate from in the year 2013 from the American Board of Orofacial Pain, and she has also done a 2 years extensive full-time residency program on orofacial pain and TMJ disorders at New Jersey. She has also undergone intensive training in interdisciplinary pain course at Jeslow Hospital, and also studied on pain and palliative care at AIIMS, Delhi. She has been delivering and conducting a lot of lectures, courses at the national and international level, and she is also an academician in the true sense that she is a very active reviewer and also on the editorial board of the Indian Journal of Pain. She practiced at Mumbai, that's at the Neurocare Center at Mumbai, and her niche or forte includes the treatment of migraines, cluster headaches, tension type headaches, primary headaches, myofascial pain, neuropathic pain, including trigeminal neuralgia, burning mouth syndrome, obstructive sleep apnea, and the TMJ problem. She has been excellent at her work, and she believes that her healing gifts are due to the sum total of her understanding with the various modalities of manual therapy, counseling techniques, and acupuncture, combined with the modern day techniques of pain medicine and physiotherapy. She is also a very busy practitioner and also a consultant at the Jesloke Hospital, at the Reliance Hospital, and also she has been associated with the Sneha Hospital. She has a practice at Neuralgia, Mumbai. Ma'am, thanks a lot for being gracious enough to accept and to be the speaker. And we look forward for very interesting deliberation through the day. Thank you very much, ma'am. And I request you to kindly commence with the session on the topic of orofacial pain, which is dentist enigma. Thank you.
Dr. Shruti? Dr. Shruti?
Yes, ma'am. You can share your screen, ma'am.
I should share my screen. So a very, very good morning to everyone here. And thank you so much, Dr. Babu, Dr. Naik, for such a warm welcome. ABSMIDS memories are all about warmth. And it's my pleasure and honor to be a part of event being held at the prestigious institute. And I must congratulate you for having the orofacial pain clinic, which is really, really required in India as of today, because I really see a lot of suffering every day and ask myself, why is it that education is missing in my country? You know, I have a big story with my life, like all other lives, and it took me 10 years of my life to come up with the funds, resources, opportunities, and everything to get admission to a US university, get trained appropriately, and come back to my country and serve my people. But now when we are about 4 or 5 full-time trained doctors in orofacial pain, why is it that education is still missing in our country? That is why I wholeheartedly teach whenever I get the opportunity. I do get oral medicine students as interns in my office who can come, observe, discuss the cases, and share. But unfortunately, most of them decide OFP is not for them. Okay, so we'll get into that later, and we'll begin this lecture with prayers to Lord Ganesha. Okay, and his thanks for NeoCare to exist. NeoCare at Mumbai deals with all kinds of pains in the head and neck region. And my very, very special thanks to my clinical mentor, Dr. Gary Hare, and my friends who pulled me through the times. You know, when you are a resident in US, it's extremely demanding and extremely hardworking. And I studied with a 5-year-old daughter. So it's their leadership and mentorship. Dr. Hare let me work from 6 o'clock in the morning till 7 o'clock in the evening, which was rare in United States. But that's what brought me where I am. And my special thanks also to my research mentor, Dr. Eliav, and Dr. Sandesh Maiker. Dr. Eliav with OFP, and Dr. Maiker has been like a life coach, because he taught me, Each person's life is at its own pace. So follow your path. He contributed immensely to keep me on the path of OFP, because it took me a lot of grit to practice orofacial pain exclusively as a specialty after coming back from US when nobody knew about the subject. And he was one of the people instrumental in encouraging me and following my path. So thanks a lot to him. And we come to our topic, dentist enigma, the confusion and plethora around OFP. What creates ambiguity in life? Ambiguity is created by lack of understanding, lack of knowledge. When things start clearing up, then there is a clear path to it. So it is a dentist enigma because of gaps in the training for orofacial pain. Okay, but that's how the whole world progressed. We in India still have that little bit of feeling of, I think years of oppression and being governed by other countries. That feeling is still lingering in us. But this, I tell you, has been the story of every country. Every country had to walk that path. But Dr. Weldon Bell existed in United States in 70s. And there were a bunch of people who pursued. My mentor, Dr. Hare, is a student of Dr. Bell. So we heard a lot of stories of their training journey. So please, anybody who wants to pursue this path, educate yourself, educate yourself. Okay, so that's my story, 10 years of dental and corporate experience. I did my MDS in 2013 and also my clinical fellowship in the same subject. I'm a diplomat American Board of Orofacial Pain. We all know Dr. Sunil Bulabai and Dr. Prashant Hatkar. Mumbai, we talk about dentists who get the board accreditation. Now there are a lot of periodontists in India who have got the board accreditation from United States. So orofacial pain is also a specialty, and we can get the board accreditation from the same country by fulfilling their criteria, which means you have to undertake rigorous training in the subject and clear the exams. Okay, so anybody who wants to pursue that path, please go look up the American Board of Orofacial Pain, and their website will give all the details in there. This is an interdisciplinary. Now, what is the foremost authority for pain in the world? It is International Association for Study of Pain. And there is the Indian chapter of that. And in collaboration, there are times when they keep holding the interdisciplinary courses. I recommend, encourage, and suggest everyone interested in this subject to please look up these things. Tata Institute in Mumbai keep doing a lot of CME activities for the cancer pain management, or something like mini residencies on pain management, opioids in pain management. So pain management is a world in itself, and we need to educate and explore those opportunities. Those do not exist in the dental system. So we need to look for them. And in India, I think Tata has great cancer pain management training programs. And when we are like today, I'm aware that I am known for non-interventional pain management, and people come from all over the world today for non-interventional pain management. But this has been a process for me, and anybody pursuing pain has to train in intervention first, because there are still times when you have to control the pain by interventional procedures and then manage it by non-interventional things. So CIPN is an academy, and we conduct yearly courses here. I work with Pain Clinic of India, and under its umbrella, these conferences are held every year. And when we have enough orofacial pain interested people, we do a special workshop for them, or these are cadaveric training interventional programs. So you can look them up too. Palliative care is a very, very important part of pain management. Pain management is about maintenance. Pain management is not about cure. As dentists, we are very tuned into a patient coming in, doing a class 5 filling, patient walking out. Patient coming in, doing a crown prep, making an impression, patient walking out. But pain patients are chronic pain patients. You are married to them. You have to learn how to live with them. You have to learn how to love them. You have to learn how to keep them comfortable. Okay, so I learned palliative care because I had to manage a motor neuron disease patient. So when motor neuron disease gets progressive, dysphagia sets in. Now, how do you console such an old man who will be struggling, and they are at end of life? Okay, so you don't do a lot of dental treatment for those people, but just manage it. So these courses are held at different institutes in India, and they're very useful in day-to-day clinical management. I'm a reviewer for 2 journals, and I'm trained with acupuncture and various manual therapies. Now, when you put all these things together, it is only then that we are able to put and pursue non-interventional pain management and put the thoughts together. 2 loves of my life, my daughter and my neocare. Okay, so what is pain? It's Dr. Vidya explained very well different aspects of pain. Now, this is a definition, but what is it that we need to do in day-to-day life? We need to start observing the patient as the patient walks in. Somebody will walk in very happily, sit in a peppy mode and say, hey, doc, you know what? This tooth is bothering me a lot. This keeps popping up with pain every now and then. And somebody will sit to you and say, you know what, doc, my life has come to an end. I can't eat, I can't sleep, I don't know what to do. Now, the management for these 2 people is going to be different. So you watch them, how they are talking, how they are walking in, uh, what kind of expressions they have during the history taking process. Okay, so it is an emotional experience, and we have to deal with the emotions in the appropriate way. Okay, in dentistry, like I said that, and I repeat myself, because that thought process has to be broken. And I know when I went for my training, it took me easily 3 to 4 months. And mind you, we went for full-time training, and I went to learn orofacial pain after 10 years of active career in dental industry and with dentistry. So those of you, I'm sure there must be somebody in AB Shetty who would remember the cervical restorations lecture, or when we introduced the nanomers and Z350 had come in. So this is the same me, right? But I had to undergo total transformation and reformation in terms of my thought process to come to being orofacial pain. So it is possible for anybody, but this transformation is essential. Okay, and we need a lot of people in India. Somebody from today's talk, please get inspired and start working for orofacial pain. Dental pain is what is the commonest complaint with which people come. It happens for different reasons: sharp shooting pain, dull achy pain, so different types of pain fibers, right? Commonest seen pain is dental sensitivity. Like everybody, whenever you are sitting in a gathering, in a social gathering also, people will start telling you, I get some sensitivity on this tooth. What is the toothpaste that you advise me to use? But how many of us think of it as a neuropathic process? How many of us try to understand what's the difference between the different available, anti-sensitivity toothpaste, and what is their mechanism of action, and how are they going to affect this particular complaint of a person? Okay? That's what is orofacial pain, the thought process. It's very essential to break down what the person is talking into the physiological understanding in our head before we can say something. So this is the process, right, which creates dental sensitivity. So what is the significant part here? You see action potentials. The last thing is action potential. So action potential is the nerve conduction which has started to take place, right? So we have to understand that everything that we do in dentistry is some or the other form of trauma to the upper part of the body, but body heals beautifully, and that is why we don't see a lot of pain. But now, say somebody did a perfect root canal, radiographically looks good. Whenever you try to evaluate it in all the parameters, it is sealed appropriately. but still the pain does not resolve. Okay, now what is it that's happening in that patient? There is a type of deafferentation pain that is set in. Every time we do a root canal procedure, we have induced the minor neuropathic trauma to the human body. Okay, and body has to heal. Now, deafferentation pain is when that healing, simply talking, when I say that now forgets its path back home. Okay, and patient will start feeling pain. Now, this is a type of neuropathic pain. No amount of dental work, no amount of re-root canals will resolve this pain. This has to be managed by the protocols of neuropathic pain for deafferentation pain. Okay, so these kind of things create a lot of enigma in dentistry, and there are a lot of such things that a lot of such examples. I have 1 hour here, and so I can't go on and on. I know that. So, but there are a lot of such examples which exist. We need to understand that these need to be managed by the protocols of neuropathic pain and with some training. Okay, as a general dentist, it's the most difficult job. You are at the forefront for differential diagnosis. My job becomes today very easy, because when everything is done, that is when the patient will land up for me. So I know that this patient has to have some chronic pain problem only. But as a dentist, as a first person which they meet for that pain, that differential diagnosis is not easy. Maybe sometime in future, we'll have a talk on differential diagnosis in orofacial pain. Okay. So who is treating this system? You may have problem with your temporalis, anywhere in your temporalis, and accordingly the pain will come either to your canines, premolars, molars. And what is patient coming with? Pain in the tooth. Very convinced. I tell you, it's very difficult to explain these patients that there is nothing wrong with your teeth and it is coming from somewhere else. And trigeminal system is different. There are enough pain specialists, and I work with pain specialists. A lot of my talks and lectures nationally, internationally have happened at the pain symposiums. I've spoken more on the pain symposiums than on the dental platforms. Why? Because this is just to carry forward the message that there need to be people who take up and own the responsibility with trigeminal system. And trigeminal system, nobody, you have to be a dentist to be an orofacial pain specialist, because you have to understand the trigeminal system, and it's only then that you can be an OFP specialist. So why is it that pain in this part is different? Because we have very high resistance to neuropathic pain in this part. Like I just said, what is the incidence of this type of pain with after root canal? 3%. What is 3%? And amongst the number of cases that we are treating. So very, very high resistance to neuropathic pain. So resilience to injury. The only organ in human body which comes twice, right? We have deciduous teeth and we have permanent teeth. So we have programmed demyelination happening in this part of the body. So it's different. The pain phenomena is not simple. See, I have traveled to many, many different places in the world to observe for pain, how orofacial pain is being practiced in different parts of the world. And what I see is that in India, we have a lot of mixed disorders. On an average, I see 10 patients to 12 patients a day. And in these patients, maybe one of them also on a day, if has one disorder, it is great. Most of them will have 2 or 3 problems in the pain diagnosis. So it is very important to do the differential diagnosis of orofacial pain itself for these patients. Why does this become so intense in this part? Because of convergence. How the pain is traveling, what their unique referral patterns are in this part of the body. So you may have your trapezius is also giving input to the trigeminal nucleus. Your neck muscles are also giving input to your trigeminal nucleus. All your teeth and the periodontal structures, everything is giving input to the trigeminal nucleus. And that's where a lot of processing is happening. So that's physiology of orofacial pain. If you read and understand that, you will start getting some insight into it. Okay, so orofacial pain, what is it that this field encompasses? Assessment, diagnosis, and treatment. I know I have questions from the participants on the management and treatment. That is it possible to do treatment or management? Yes, it is very much possible to do the management with the right training. Okay, so pain of dental origin and a lot of pain of systemic origin also comes in the orofacial pain part. And there are many such cases. I'm not a person very inclined for publication work and all of that, maybe at some point in time, but we have a lot of cases with autoimmune disorders which reflect and begin as orofacial pain. You know, something like P vasculitis, which is an orofacial pain, which is an autoimmune disorder. And this patient had come from Bhavnagar, Gujarat, for unresolvable pain. And before we could diagnose it, it took 2, 3, 4, 6 doctors to work together to come up and say that P vasculitis. So, but who led that to that path? Who was that person who put the finger on that maybe this is it? Orofacial pain specialist. So that has to be the thought process and differential diagnosis with orofacial pain. A lot of time, rheumatoid arthritis will begin in this joint. Systemic lupus patients have a poor TMJ joint. And so we have to work with their respective specialists and keep them pain-free. Whatever medications they are taking, whatever they are doing, that is not bringing them pain relief in the upper part of the body and renders them dysfunctional. So we have to keep that in mind, systemic problems, okay? Pharmacotherapy, physiotherapy, rehabilitation, everything we have to have an idea of when we are working with orofacial pain, okay? It is a multidisciplinary team. It needs a lot of coordination, okay, the right word. And sleep disorders are very common. I don't know if it is all over India or is it only Mumbai. I cannot comment on that part. But in Mumbai, for sure, I see a lot of suffering because of sleep disorders. And by sleep disorders, it's not obstructive sleep apnea alone. If I have my Insta handle, Ruchika9773, and I keep putting some patient testimonials there, one which I feel were complicated. So we have patient testimonials there on sleep hygiene, or patients whose sleep was managed and 100% out of pain. So there is a priest whose testimonial you can find there, who was with headaches for 17 years, since age of 45, so 27 years. And then we worked on his sleep correction by the sleep hygiene protocol and yoga and meditation, and we could correct it. My research when I was a resident was on exercise-induced analgesia. So I use a lot of that understanding in yoga in the patient management in day-to-day life. Okay, I work with a very good yoga teacher as well. So that also makes, if you have the appropriately trained person with you, you can do a lot of work in that space as well. Okay, in United States, it's very high epidemiology. In India, 30% of the IT workforce, which is young, 25 to 35 years of age, will have neck pain. Neck pain, biggest cause that I see in these people is posterior cervical group of muscles. Now, posterior cervical group of muscles, when they have been stressed for a long time, can they bring about the changes with the alignment of the cervical spine? Can that affect the TMJ? Can that come as a referred pain on a zygoma because of the masseter activity? So all of these things happen. And we need to be able to treat these people in India itself. I see a lot of suffering. So diagnosis is the key, and diagnosis is the skill which is required for OFE. My teacher, Dr. Hare, always used to say, it's a job of Sherlock Holmes. You know, you take away everything, and then what remains is what is your diagnosis. So one by one, layer by layer, be very patient, listen to the people, correlate lab findings and x-rays, and diagnose. Diagnosis is the key. We have enough content as our guiding light for the diagnosis. See, when I started my journey in orofacial pain, it was way back in 2009. 2009, this is 2021. So I've witnessed a lot of changes and I've walked the path, and I have grown and evolved with the learnings that kept coming with time. So IHS International, one of our teachers when I was a resident was also Dr. Benoliel. So Sharaf and Benoliel, the orofacial pain textbook. Yeah, so Dr. Benoliel, we also had the opportunity to be with him, and international headache guidelines which have been written, Dr. Benoliel has contributed immensely to that. So in 2013, 2015, I think these have come very recently, and they have TMJ headaches as one of the diagnoses there, okay? But headache is a common problem, but the mindset of most of the people, we did headache camps in India, in my office in Mumbai, in the hospitals where I'm working, and people showed up, and not many of them came back for treatment. You know why? This is the most surprising part, because they accept and believe it as a normal part of life. When I ask people, so there was no problem before this. When was the first time you had this headache? हाँ डॉक्टर वो शुरू हुआ था, लेकिन वो नॉर्मल वाला हेडेक था. So this normal wala pain and normal wala headache is a very big problem for doctors, because they come to you at the last possible step when the excruciating pain, when it is spoiled beyond all limits. Okay, but IHS does explain the guidelines. Everybody who's interested in it should read it. American Academy of Orofacial Pain has a book, René book, which talks about the guidelines for diagnosis. And the latest are the research diagnostic criteria, which have very, very extensively given the guidelines for the diagnosis in orofacial pain. Okay. Now, what is the current status? Most dentists and doctors don't treat. You know why? Because 78% are not sufficiently trained, and 64% believe patients are too complex. Patients are never complex. In my practice, every person who follows the path. See, there are patients who give up in between. There are patients who make an opinion about the fact that they don't want to complete their treatment, or they don't want to pursue this. They want something fancy and surgical. But all those who walk the path, they recover. They get their life back. Okay, so patients are never complex. We just have to understand. Like my mom taught me when I had my daughter, like, you know, बच्चे की कभी गलती नहीं होती है, गलती हमेशा parents की होती है. Because what you plant, the sanskar that you give to your child is sanskar is given not only after birth, sanskar is given in the garb itself, right? So garb sanskar से लेके 12 साल की उम्र तक के जो संस्कार है वो maturity develop करते हैं एक individual की, वो discretion develop करते हैं. So similarly, no patient is complex. It is our training and our understanding that we need to bring to the level where we can understand our patients. Okay, and we have to know what is an appropriate referral, because there are times when I need a lot of times second opinion, advice, consultation. So we have to be a part of group where we know where we can discuss and bring the treatment. There are questions about PRP in the questions list that I received. I do not do PRP treatment myself, but I work with my team at Apollo Clinics, and I have a colleague of mine who does the PRP treatment. So one person cannot do everything. So far, we have 5 specialists who have full-time residency-based training from United States. And I feel there is a lot of orofacial pain is learned only by working on the patients. That is why I accept, students who are oral medicine students and want to come shadow, learn, because this is the only way that it can be learned by observing patients. So now classification, everybody knows. It is of different types, right? You can look at it duration wise, you can look at it where it is nociceptive pain, non-nociceptive pain, okay? And everybody knows that this is Bell's orofacial pain, axis 1, axis 2. Why I put this picture here? Because we look at axis 1 very, very evidently. When it comes to axis 2, patient is dismissed. This patient has a psychological problem. Boss, if somebody has to sit at home for fever for 3 days, what is your state of mind on the 4th day? When you get out of that viral fever, and when you 4 or 5 days of that sickness is enough to take away the brain of a person, right? What do you expect from a person who has been suffering for years altogether? So there will be some component of axis 2 in that person. The key here is to understand that axis 2 as well in relation to the axis 1, and then manage the patient. Don't dismiss that case saying a psychological patient. A psychiatrist cannot manage them. Psychologists cannot manage them because they have a real pain problem. That real pain problem has to be treated first. And then the coping skills have to be developed in those patients, or you have to work in conjunction with them simultaneously. Okay. So diagnosis and understanding of the patient is key. Every pain here is assumed to be dental until proven otherwise. Where is the diagnostic challenge? Because this is a very, very small region. Okay. The broad categories of orofacial pain. Okay. I looked through the questions which was sent at the time of registrations by most of you, and I actually changed my presentation yesterday. You know why? Because they were all over the place and there was no way I could do justice to that expectation any other way than this, where I have just categorized pain into broad category and taken a patient history to explain the point. Okay, so myofascial pain syndrome is one of the commonest problems. 70% of the problems in this part are coming from the muscle component, or the musculoskeletal. Okay, that is the epidemiology of pain in general. So we really need to understand. Theoretically, each one of you can go back, read orofacial pain from Benoliel and Sharaf, read Dr. Shah's papers on myofascial pain, read Weldon Bell, and watch some seminars and lectures from the University of Pennsylvania Oral Medicine Department. They have good presentations, and I think also Louisiana University had some. There is an internet program by Dr. Partis, which is being done at Rutgers University, which is also a very, very good program. And there are a lot of fellowships available, so you could look at those options and train yourself on it. This is one patient who's going to talk her history. Please listen to it and see what sense can you make out of it.
यहाँ पे जो दर्द है हाथ लगा के बताइए कहाँ पे? यहाँ ऊपर। कब से है? अभी 2 साल हो गए। नॉन स्टॉप है ये दर्द 2 साल से? हाँ? रुका बीच में ये दर्द? हाँ बीच में रुका था। 4 दिन रुकता है। तो वापस इतना दर्द हो रहा है कि पानी पीने को भी नहीं मिलता है। इन 2 साल में इस दर्द के लिए आपने क्या-क्या किया? गोली, दवा, ऊपर से मलहम अंदर से सब कुछ लगाया, बहुत सारा। उसका गोली मिली का कागज नहीं, मगर वो सब है, दवा सब है मेरे पास, ट्यूब भी मेरे पास है सब। ये कैसे चालू हुआ था? एक दर्द दांत होने लगा ना इधर का, तो एक के ऊपर एक निकलने लगी तो दूसरा निकलने लगने लगा, फिर भी दर्द चालू हुआ, फिर रुका तो ये दर्द निकाला, दांत निकाला, तब ये बहुत दर्द करने लगा। दर्द का तो बहुत ही दर्द ही रुका ही नहीं। जब चालू हुआ था तो ये क्या दूसरी साइड से चालू हुआ था? अभी आपको राइट साइड पे है ना? हाँ, इधर ऊपर। तो पहले क्या लेफ्ट साइड से चालू हुआ था दर्द? कैसा दर्द ही होने लगा, दांत से चालू हुआ था ना, दांत से चालू हुआ, सबसे पहले दांत दुखा, हाँ, पहले सबसे दांत दुखा, और फिर उसके बाद वो नहीं दुखा था, पहले सबसे दांत ही दुखा। उस दांत का कोई इलाज करवाया था? हाँ, किया था। क्या किया था? इलाज मतलब वो क्या ये करके मैं उसमें चांदी बिंदी भर के कैप लगाया था, फिर कैप भी उपाटना पड़ा, उतना ऊपर में कैप लगाया था, कैप लगा के फिर उखाड़ दिया, फिर दर्द चालू हुआ। ये जो दर्द है, अगर मैं कहूँ 0 का मतलब है कोई दर्द नहीं और 10 का मतलब है असहनीय दर्द, तो आप इस दर्द को क्या नंबर दोगे? मतलब बर्दाश्त नहीं हो रहा तुम्हाला, बर्दाश्त नाही हो रहा है उतना दर्द, मग तुम्ही त्याला काय नंबर देणार? 0 म्हणजे नो पेन आणि 10 म्हणजे एकदम सहन होत नाही तसं त्रास.
See, patients always find it difficult to objectify their pain. Very difficult to get this answer. So the other question you can ask patients to get the intensity is like, रुपए में कितना पैसा आ रहा? That works. When I was at AIMS, I realized that is how they comprehend it for the Indian patients, and they comprehend it better this way. When you ask them, like, रुपए में कितना पैसा तकलीफ है आपको? So, I mean, then you can give them a vast scale to draw it, like where is your pain, and see if you can get some objective assessment of their pain.
अच्छा, अगर आपसे पूछूं ये दर्द कैसा है, कोई छुरी काटती है, कोई सुइयां चुभती हैं, कोई मुक्के मारता है, कैसा है? आप अपनी मराठी में बोलना है मराठी में बोलो, हिंदी में बोलना है हिंदी में बोलो, पण तुम्हाला ते दर्द कसं वाटतं?
Okay, so sorry. Oh, sorry. I gave you the diagnosis beforehand. Oh, okay. So this was the important part, that when she's explaining what type of pain is that. Okay. So what she's saying is that at this part, she has to rub and she feels little better. And she says that there is throbbing pain, tap, there is throbbing pain there. And she says that there is a dull background achy pain all the time. Now, these are all different diagnoses, but one patient talking. And this is how we dissect the different headache disorders. I hope there were 2-3 questions there about different headache disorders. So this, the main diagnosis of this patient is facial migraine, which I see very commonly, at least mahine mein 3 or 4 patients I see with facial migraine. Okay, so what is the treatment line for them? No amount of dental treatment. This lady had tried to end her life with suffering. She has no teeth present in her mouth. All the teeth had been extracted in the name of trying to do the treatment. Who was her first stop for this management? Dentist. She has been to multiple dentists and a lot of other doctors as well, physicians and those, to figure out in ENT specialist what was happening there. Okay, so we started her on beta blockers and she felt better. But along with the facial migraine, she also has trigeminal autonomic cephalgias. So that was the background dull achy pain in this part that she was talking about. Okay, and that is treated by indomethacin. So how did we know it is that? By doing the endo test. Okay, and she also, with all of this, she also had myofascial pain, which may be secondary pain, because with so much of suffering and unresolved pain, it is possible to get secondary MPDS. So we had to manage that and bring her out of that as well. She's still on beta blockers, but pain-free and living happily, has got a denture done for herself, comes every 4-5 months to renew her prescription. And see, so it's very important to listen to your patient and understand what is the main diagnosis. So if you want to understand different types of headache disorders, read them. IHS gives the classification, characteristics of each, duration of each, presentation of each is different. And we can do one lecture on headaches and talk about it more in detail there. Okay. So, and then we have TMDs, spoken about. One TMJ can treat all the problems in the body, right? By one joint, one TMJ pain problem resolution treats everything in the body. That's the real joke, because this is a joint, like your knee joint, like your pelvic joint is a joint like joint. Just that it has, this is one of its kind. But the basics of a joint are always there. There is a capsule, there are ligaments, there are structures which hold it, and we have to manage all of them and understand that anatomy and biomechanics and correlate it with the physiology of the pain. I repeat, understand the biomechanics of TMJ and correlate it with the physiology of the pain. And that is when the diagnosis can be arrived at. Okay. And then the epidemiology of orofacial pain is of TMD disorders is very high in Brazil. We do not have data available from India. Well, I'm talking on an academic platform today, and maybe I'm reaching out to a lot of academicians. So let me take this opportunity that my heart really yearns and desires that we do very good research work of orofacial pain in India. I do not have a platform to do it, but I do have a lot of gray cells with me to work on different kind of research projects for orofacial pain. I have exposure to best possible modalities in the research, and I'm trained on the latest phenomena with pain management. But I do not have a platform as yet in India where the research can be conducted. And it is really required. Why? Because Asian population is different from the Western world. The neuropathic pain consensus papers are there, and they are our guiding line for treatment of neuropathic pain. If you start management of patients with so many drugs at so many dosage, at that kind of a dosage, Indian people do not comply very well with it. And this is an observation. We need to have studies. We need to, scientifically evaluate a lot of these things and present it as how they work for the Asian population. Okay. So sphenopalatine ganglion, somebody asked me this question in the questions that what is the latest for management of BMS? I'll come to that, but because we're talking, so burning mouth syndrome, one of the things that they were talking about is sphenopalatine ganglion, an interventional procedure. But for us in India, there are a lot of therapies which exist. Nasyan is a concept in Ayurveda. Okay, so how does Nasyan work? There are a lot of different things that are used there which bring the neuropathic inflammation down. All pain is sustained by neurogenic inflammation. We understand that much. We know that it is all the game of those interleukins and cytokines. All that we need to do is bring that neurogenic inflammation down and somehow throw the inflammatory soup out of the body. So that is what these modalities are doing. But I do not really have a platform where I can, collaborate to work and have evidence-based outcome out for larger use and of the public. But it is really required. Here also, see, I'm quoting the even epidemiological studies. I'm quoting a Brazilian study because I thought that's a developing country. Maybe the data is same. We do not even know what is the epidemiology in our country. Okay. So we need to work. We need to work on this. Where will we find the answers on the patient's problems? By listening to them. We really need to listen. Empathy and compassion is the first trait that we need to listen to the stories of each of our patients. It's a beautiful world of orofacial pain. It is because you really see the essence of existence by being in service to this profession. Okay? So we were talking about TMDs. When we talk about the joint problems, a lot of times it's about the articular disc problem. So it will be arthrogenous or it will be myogenous. When we look at a joint problem, it will be arthrogenous or it will be myogenous. But then broad category we will put there. Here I have taken a case which is a little more complicated than that, because I believe that the basic TMJ cases get diagnosed in dental clinics today, and especially when OMDR people are treating it, I mean, that's not a very difficult thing for them. Okay, so this patient came with a preauricular area which was extending from zygoma to angle of mandible, headaches and neck pain. Okay, these are 3 different complaints. We have to evaluate them. And the history of present illness, patient has started all this after a dahi handi fall. Okay, and it has been getting worse over the years. 3 ENT specialists, 2 neurologists, 6 dentists. All these people will have the highest number of dentists on. I have seen up to 17 dentists visited by a patient and no cure. So when we did the examination, see, MPDS will be there a lot of times as secondary pain in many patients. Okay, the important thing is when you look the joint, how do you look at it? Joint is like any other joint. How do you evaluate a joint? By the sound of the joint, by the gait of the joint, by the range of motion of the joint. Okay, so those are the parameters on which we evaluate even the temporomandibular joint. Okay, not occlusion. Evaluate joint like joint on the parameters of gait of the joint, range of movement of the joint. Okay, and the sounds from the joint. Okay, this patient had a deflected joint to the right. Okay, we did the evaluation for the patient, and we found that everything here was normal. On CBCT, there were no significant findings, but we did not leave it there. So we did the ultrasound. Once we did the ultrasound, we had lymphadenopathy as diagnosed, and what I was suspecting in this patient was a thyroid problem. Why? Because where is the processing of pain happening? HPA axis, hypothalamic pituitary axis. Okay, if that axis is disturbed, the intensity of the pain is going to be much more. So the patient was not having any obvious thing, clinical finding other than the MPDS, but the intensity of the pain was excruciating. His eyes were red with pain and tearing. Okay, so then we could figure out his thyroiditis. This was managed by the appropriate medical doctor. Okay, and what else we did was ultrasound. We did the trigger point manipulation for him, and pharmacotherapy, which was Primox, nortriptyline that we had given him, and the splint which was made. So he found relief after 10 years, 12 years. I don't know. Now, is it that this case has been dismissed from my office? No, this was recorded a few years ago. I think he's a patient for last 4 to 5 years. So he is talking a lot of his journey and history with what I just stated.
तुम्हाला काय त्रास होतोय, म्हणजे तसं तुम्हाला त्रास कुठे दुखत होतं?
So I put this video because you see the location, how he is putting his fingers there. This kind of an excruciating pain is very easy to confuse
आणि
with
ते कसं
neuropathic
दुखत
pain
होतं
and
म्हणजे
go more towards
curls
glossopharyngeal
होतं,
nerve and all. I have seen people being ablated for glossopharyngeal neuralgia with this kind of pain, which was not the diagnosis. So why
आणि काय करायला
how will
तुम्हाला
you say?
बरं
He
वाटेल?
says
काय
this.
असं काय करू शकत होतं तुम्ही की
He's
तुम्हाला
not
बरं
saying
वाटेल?
this. Neuropathic pain is more very well defined. Patients will talk very definitive. They will never
आणि
put
काय
this.
करून तुम्हाला सेक करून चांगला वाटत होतं?
So that is what I wanted to highlight with that you listen to the patient. I know I don't record pre when the patient just comes. Some of them I have because patients need empathy. Patients need understanding at that point in time. They don't want to be feeling like a product because they've been to too many people. They've been through a lot. So they're almost convinced they cannot heal. Okay. Now, so another thing about the joint problems that I want to say here is because sir mentioned a lot of some orthodontists are also there. So most of the orthodontic referrals that we get or the problem that the orthodontists feel with orofacial pain are two ways. One are the TMJ disorders, and they in ortho practice, they're very straightforward TMJ disorders. They are usually not very complicated. Articular disc disorders may be there, or disc displacement with reduction. Some people develop it during the course of orthodontic treatment. It is possible to manage it. Most of the time, when my referring doctors have sent me these patients, we have been able to manage it without abandoning the orthodontic treatment in middle. There are, I think in last 1 year, about 2 patients where we had to cut open the wire and take away everything, wait for 2-3 months to restart the treatment because that was disc displacement without reduction. And a lot of these people are teenagers. And now, like I said, we really need to research. We really need to get our own data in India because what I'm observing is that lifestyle has a big role to play. I'm a reviewer for Journal of Midlife, where I get a lot of these kind of articles and work, but hardly anything from India. But so this needs to be evaluated evidence-based, but this is an observation that most of these youngsters have very screwed lifestyle. All of them got into trouble. No time for sleeping, no the dietary instructions that are given were not followed appropriately. So was that a reason? Most of them, half of them say that they had a problem with the joint when they start to bite a burger. So that is one thing. And the other thing is the sleep disorders, obstructed airway. So airway assessment, I feel personally should be a part of the cephalometric analysis only before starting the ortho treatment. If a person has an obstructed airway, they should be at least given a heads up information that TMD and OSA are comorbid conditions. So if somebody has a problem, has problem of sleep obstruction, they are prone or they have higher chances or incidence of TMD being manifested. So we can have a separate talk on TMD and obstructive sleep apnea and their pathways and how all of that works. But these are two common things that I've seen with the orthodontic referrals. Okay. With this, I come to neuropathic pain. And this is one of the patients who was kind enough to record.
I would like to share some experience with you. Before 7-8 years, I was diagnosed with trigeminal neuralgia, and I was being treated for that. Initially, the pain was less, so it was okay, but gradually it started increasing, and it increased so much I had to take a very high dose of medicines, which made me feel dizzy throughout the day. And I couldn't even walk properly. I was in the pain throughout the day. So then I was thinking of going for operation. When I inquired with the doctors, they say my facial nerves will be damaged and they'll be paralyzed for 2-3 months. So I started looking for other options, and then I met Dr. Ruchika Sood and I started her treatment. When I first met her, my pain was to a scale of 8 out of 10, and it was very severe, so almost throughout the day. But then after 8-9 months, it has come down to 1 to 1.5 and very occasional. And now since last 1.5 months, I've stopped taking any medicines. The pain is same level, 1 to 1.5 and very occasional. And otherwise I'm fine. I'm Dr. Ruchika Sood. Thank you.
So what is this kind? Not every pain that is happening in this part is trigeminal neuralgia. Most of the patients with this kind of pain are, I think trigeminal neuralgia should be labeled as one of the most commonly misdiagnosed problem. So she has persistent dentoalveolar pain, which is atypical odontologia, the phantom tooth pain, and has to be managed by the neuropathic pain protocol. These people, her pain is at 1.5 to 2. So you have to teach them acceptance that this much of symptoms, but she's living comfortably and she's very happy with her life. She's not living in excruciating pain anymore. She's working. She's 70 now. She came to me about a few years back, right? But she comes every 3 months, renews her prescription. We do some tests to see if the nerve conduction is all right, and people live happily with that. With the correct diagnosis and correct management, brings a lot of change to people's lives. Not every pain is trigeminal neuralgia. I've not touched trigeminal neuralgia because I know that is coming in. And the other common, so this is one problem which we see in neuropathic pain, persistent dentoalveolar pain. And this is a type of deafferentation pain, has to be managed by the protocol of neuropathic pain. This particular patient has been on a combination of nortriptyline and clonazepam for some time. And like she said, she's off medications. How do people come off medications? Because I work a lot with exercises, with yoga, with meditation, and then they can sustain it by managing their lifestyle. Okay, this is a case which one of my students had also presented at an oral medicine pain conference, and she's done beautifully. PTTN, that is peripheral traumatic trigeminal neuralgia. Neuropathy. Peripheral traumatic neuropathy. So this is very, trigeminal neuropathies are more common, I feel, than neuralgia patients. Or we don't get to see them. They will go, maybe neuralgias will go more to neurosurgeons. But neuropathies are seen very commonly. And the reason for running over this history is so that you can get an idea of how do these people present when they come. So this started for her in 2008 as sudden severe sharp shooting pain when she bit on a laddu. So was that a cracked tooth syndrome? I asked myself this when I met this patient for the first time, and I asked this, this is a probability. Did the dentist do the wedge test for this patient at that time? No, it's such a basic and simple test. But how many dentists in day-to-day practice do the wedge test? It's very useful. I have seen patients of cracked roots and cracked tooth with excruciating pain being labeled as orofacial pain patients and landing in my office. Okay, so keep that in mind. And then patients are referred to neurologists and neurosurgeon. Interventional treatment was done. See, it's like this. If an OFP patient reaches a prosthodontist, that's the line of treatment. If they reach a neurosurgeon, that's the line of treatment. So whichever doctor they reach is the line of treatment until they reach the OFP office. Okay. These were her meditation, and she had relief with intervention for 4 years. Then again, the pain started. medications were started again, starting with Tegretol, carbamazepine, good old carbamazepine, which is used a lot. A lot of patients on carbamazepine come to my office with the problem of, or oxcarbamazepine also, with the problem that they are not able to function. See, you will not have a lot of high profile testimonials on my social media at all, because none of those people are comfortable recording. Why? Because it's a limitation. It's a limitation. If somebody, so you have to be really careful of guarding somebody's personal history. Pain is a very, very sensitive thing. And when they get into excruciating pain, they don't want their career prospects to be damaged because of this. So lot of people who are on Tegretol get into forgetfulness or diminished cognitive function. And that is when they come to me that you work non-intervention, so can we get off these medications? Okay, so I know that a lot of people can do without medications if sequentially worked on. Okay, she had no relief. Then again, another intervention was done. This is 2014. Okay, no relief. Okay, 2015, she comes to Mumbai and has CT guided radiofrequency lesioning of the trigeminal nerve with different drug combinations again. Then also no relief. And then we did, these investigations were done, MRI was repeated, and another intervention, fourth one for her. Okay. Now, this brought no relief and excruciating pain to her. Okay. This is when she landed in our office. So we started with the history. Again, all the parameters, sleep is disturbed. She was very disturbed emotionally because she had 2 children and they had come from a different city. And she could not even touch because it would aggravate so badly. She had not eaten almost for 6-7 days when she had come to the office. Okay, but very, very significant part of her treatment to be started was she was psychologically very wanting to fight it because she had 2 small children. You know, a mother's strength is very, very different. She wanted to be all right and was very well oriented. You know, in spite of so many medications and so many surgeries, so her orientation was not disturbed. Okay, and her motivation levels were not lesser. So these pictures are just there so that a dentist can feel good about seeing some teeth. It doesn't mean anything. What we did was we made her a stent, because when there is a peripheral trauma, you have to, the input to the nervous system is also from the peripheral nervous system, and whatever we manage with the management of central nervous system, you sometimes is not good enough, so we have to manage it peripherally. My teacher, Dr. Hare, had made a combination of drugs, which we used to call Dr. Hare's paste, which is there as a published thing today. We do not have it in India. But because the base for it is fluorolecithin, and that base I could not source at the compounding pharmacy in Bombay. If anybody in the academic circuits has a pharmacological department which can do it, please oblige us. It will be useful to many, many people. So Dr. Hare's paste is what we sourced for her, and she used it, and that brought in a lot of relief. So we make a stent and apply the paste and keep it at the part locally there. And for her, we kept it for very long hours, like 16 hours and 18 hours, like that. Okay. And provisional diagnosis of PT, we made the traumatic neuropathy diagnosis for her and we worked with it. But we had to rule out all the other options. So tests were done. And what really helped her was that one stent with local application of those drugs. And we put her on systemically, we put her on gabapentin and oxcarbamazepine. And Tylenol is Nucenta, or Tylenol is synthetic tapentadol. This is tapentadol, which is like a synthetic opioid, so we can give it in excruciating pain. This is a sheet which such people are given in our office, where they have to really record the patient's pain. See, in hindsight, everything looks good. But when the patient is in front of you and you have to listen to the patient and really decipher it, it's not easy. It takes, there are times when I listen to everything from the patient, get all the data, and I sit in my room with instructions, do not disturb. And I need 10 cups of tea, and I'll sit and think what to do with, what should be the right approach for this patient. Because your starting points are very, very significant. How it's a process. Pain relief is a process. So this patient significantly reduced and came to zeros. You can see on the 25th day, she has come to all the zeros. So it was 25 days of working with her. And now this was a patient which was done many years back in the office. But today we can do these kind of things in about 10 to 12 days, because I'm trained in acupuncture and I use a lot of that understanding to bring the faster pain relief, especially in neuropathic pain. I think I get much faster results by using those protocols along with the medications. Okay. So we have to really understand our patients and bring pain relief to them by understanding them, being empathetic towards them, considering all the pool of diagnosis that exists, giving higher significance and value to mechanism-based pain. Okay, pain is not a mechanical process. As dentists, we are trained. How do we talk? ये class 2 है, ये class 4 है, ये crown and bridge है, ये root canal है. Now, do we say the diagnosis? What are the diagnoses for that? We don't talk in terms of the diagnosis. This is scaling. This is not gingivitis. Root planing. This is not advanced periodontitis patient. We will not say this is an advanced periodontitis patient. We will say this is a case of deep scaling. So thought process. What I'm talking about is the thought process. In the world of pain, it's very important for us to break this thought process. It's not a mechanical thing. It's a mechanism-based understanding, and we have to come to that. That can happen only with committed teachers. And I was blessed. I am blessed. I still have my teachers for all the difficult things. I have Dr. Eliav here with Dr. Hare and Dr. Sibeli, one of my researchers. She's one of the foremost authorities for burning mouth syndrome in the world. And Dr. Markman, who taught me that by being a dentist and working in dentistry, how much more of orofacial pain I can do. And yeah, he was right. If you work in dentistry for a while, you really know how to differentiate it. How, while doing a veneer prep, orofacial pain can get induced. My heartfelt gratitude and thanks for giving me this platform. My teachers, colleagues, my friends, and my family, without whom I would never be what I am. And one request to everyone to spread this message in today's world, that human body is the temple. We realize God only by being in this temple. This is the biggest blessing that every person alive has. Value it. I feel a lot of pain problems are created by the abuse of the human body, by not respecting this temple. This is the real God. Okay, you can reach me anytime with any questions that you have. Email me. I will definitely revert and answer. And the questions that were there, I have tried to address most of them that were within my preview. Treatment of TMJ disc reduction and without reduction was asked to me. And I will say that, that is not one diagnosis alone in India that I see. There will always be associated, if it is without reduction, for sure there will be associated MPDS with that. Look at the trigger points in those patients, manage those trigger points, and for the management of the disc, you will have to make the patient appliance. Okay, so make them the required appliances. We call it intraoral appliance therapy and manage it with that. Okay, and I do not know if there is any difference in the cerebral blood circulation of a patient. Somebody asked me this question: what is the difference in the cerebral blood flow with with using splints? That's an interesting question. I'll try to look it up and send the answer to Dr. Vidya, but I didn't find anything there. Okay, but somebody may have thought this, maybe that person has a neurovascular problem itself. Huh? Diagnosis of TMDs and their management is one full topic in itself. Okay, so if there are any more questions, this is the side effect of online platforms. You don't know. Hello.
We have ma'am.
So, yeah, hi. Where can I read the questions, Dr. Shruti?
Ma'am, there are questions on the YouTube channel. Shall I read it out to you?
Yep, please.
We have Dr. Anand asking, any change in the trend of orofacial pain during the COVID pandemic?
During the COVID pandemic, yeah, the changes that I feel I've seen is that, one, we have got equipped to do little of telemedicine. Second is all the protocols that we have to follow, like chlorhexidine rinsing and the masks and everything. In terms of management for the post-COVID pain patients, if that's what you want to ask, yes, there is a bunch of post-COVID pain patients which are existing. The management is done on the same principles, but I'm more emphatic on yoga being used for them, and a lot of pranayam being used for them because of the breathing things. So we wait and work for about 2 to 3 months with pranayam for these patients. And what else has changed with COVID? I think that is one thing that has changed with COVID.
We have another question. The role of cyanocobalamin and multivitamin tablet prescription to assist healing in nerve injury.
Yeah, that's a very equivocal thing, very commonly used. Most of the people, when tested for vitamin B12 and pain, will have very higher things, but it's a water soluble vitamin, so it's okay. But as an adjunct, okay, if you're deficient in it, yes, definitely you need it. But you can't load people with multivitamins and expect wish for the pain to fly away. You need to know the diagnosis of a patient and manage it accordingly. As an adjunctive treatment, you want to use it, please go ahead. Alpha-lipoic acid and vitamin B12 and all of them. But they are never in the main line of treatment, and they cannot be.
Is acupuncture better and more effective in non-surgical management for trigeminal neuralgia?
See, I don't know the surgical.
Compared to 10.
Compared to?
10.
TENS. TENS cannot be used for management of trigeminal neuralgia. How can TENS be used for trigeminal neuralgia management? Trigeminal neuralgia is a neuropathic pain. TENS can be a symptomatic management for something, but between acupuncture and surgical options, it depends upon the case. It's a case-to-case decision. If somebody has really intense pain and has exhausted all the options, then they need surgical management, and there is no way out for them. And my experience has been more with people who have undergone these surgeries and have not healed, and they have come to me for treatment. I don't think there is a good or bad amongst these. If it's left to me as an individual, I would always choose acupuncture first and then go for the surgery last. It's an individual's decision. But is acupuncture effective? Yes, it is. It is. That it works. That I can say.
Thank you, ma'am. That was a very informative session. I'm sure everyone would have had a really informative session today.
Now, may I request the participants to reach out to me on my email or my WhatsApp and let me know if it was of any use to them, because this is really strange. Just keep talking to yourself, sitting in a room and feel like you have reached out. Lecturing is a lot about your connect with the audience and understanding what they need, you know. It's not about my monologue. So maybe it would be nice if I can get some kind of feedback on this. Yeah.
Okay, ma'am.
Thanks a lot. Thank you very much for having me. Thanks a lot.
As a token of our appreciation, I request Dr. Rasika Sood to accept the certificate. Thank you, ma'am.
Thank you. Thank you so much. Thanks a lot.
If there are no other questions, I think we'll move on to the second talk of the day by Dr. Suhas on the topic PMD and images, the science of making better treatment choices. I request Dr. Shruti Hegde, the coordinator of Orofacial Pain Clinic, to introduce the speaker. Over to you, ma'am.
Good morning. It's my great honor and pleasure to introduce our eminent speaker, Dr. Suhas S. Dr. Suhas S. is clinician in the specialty of oral medicine and radiology. He obtained his BDS degree from Manipal Academy of Higher Education, Manipal, in 1996, and MDS from Rajiv Gandhi University of Health Sciences, Bangalore, in 2000. He has completed training in clinical dental research methods at University of Washington, USA in 2009. He's presently working as Head of Department of Oral Medicine and Radiology, Sri Siddhartha Dental College, Tumkur. He's the Director of Research and Development at Sri Siddhartha Academy of Higher Education and also serves as external member of Board of Studies, Dental at MS Ramaiah University of Applied Sciences. He is the director of Samhita Center for Mouth Diseases, TMJ, and Orofacial Pain, Bengaluru. He has a special interest in the oral mucosal lesions and orofacial pain, including TMJ disorders. His research interest areas include management of chronic orofacial pain, oral potentially malignant disorders, and radiation biology. Sir has designed Publishing Clinical Research Program, a program designed to train dentists to conduct clinical research, scientific writing, and publishing, with the aim of capacity building for conduct of research through practice-based network. Sir deserves a review program, a program designed to train rural dentists in the identification of oral potentially malignant lesions as well as oral cancer, to train dentists in the process of informed consent for ethical conduct of research on human subjects in collaboration with CITI, University of Miami, and Fred Hutchinson's Cancer Center, USA. Sir also developed airbag organoleptic behavioral therapy in the management of halitophobia. He developed phantom head radiology model. Sir developed cost-effective printing system for digital printing of extraoral radiographs. In addition to the above accomplishments, he has authored a chapter in the textbook Orofacial Pain, a clinician's guide, which is published by Springer International Publishing in 2014. And Sir has 34 international publications to his credit. He has been chairperson of scientific committee in various national conferences. It is such an honor for us to have you today as a resource person. Over to you, sir.
Thank you, Dr. Shruti, for that introduction. And I thank the organizers for giving this opportunity to be a part of the Pain Symposium. So I am from Siddhartha Dental College. We are a big college in a small place called Tumkur. And we are attached with the deemed university, Siddhartha Academy of Higher Education. And we are focusing a lot on orofacial pain conditions and pre-malignant disorders in our college. Then we have a really superb team. I want to take this opportunity to introduce our team members. We have Dr. Jaydev. This is Dr. Jaydev. Hello. He is a reader in our department. Then we have Dr. Sucheta. She is a part of our team. Then we also have Dr. Mahalakshmi. She is also part of the team. So the four of us manage all the pain-related lesions, conditions. Not to brag about our accomplishments, even though we are situated in Tumkur, patients travel almost 200-300 kilometers to come and get consultations here. We have patients coming from as far as Kushalnagar, Mysore, Chikmagalur, and we also take care of all the pain referrals from Tumkur and in and around small town patients and clinics. So with this, I think we'll start with our presentations. Give me a minute, I'll just start sharing my screen. Just a minute, some technical issues here. Can you see my other screen, Dr. Shruti?
No, sir, we are not able to see.
Yeah, now can you see me on the other screen?
No, sir. Now it is.
Yes.
And video digital.
Okay. Now that we've started off, I'm sorry for the delay. Anything interesting begins with a doubt. So this is what got me intrigued into the TMJ disorders. Initially, when I used to look at all the literature or the methods which were being used to treat patients, I really felt that there is something, a disconnect between what is happening in the mouth and the approach to it. Based on this doubt, I started kind of observing how the joint moves, how the joint works. Then slowly I realized that there is a really easy method to fix the problem rather than relying a lot on technology. So here today, I'm going to sort of share my experiences with understanding the temporomandibular joint disorders. And then I will also share my experience to achieve clinical success and improve the quality of life for these patients. So the points of discussion for today's discussion will be initially what are TM joint disorders, what their clinical features will be, then the pain mechanism of temporomandibular joint disorders, the etiopathogenesis, the difference between old school and new school. Then we'll briefly discuss on the philosophy of imaging, in the sense, what are the imaging techniques available for understanding TMDs, and which will help us, like just the OPG or the TMJ open and close projections are sort of adequate in the preliminary understanding of the disease and classification or diagnosis. Then the treatment options. Then I will share with you clinical cases and how I treat my patients. So when we look at the TMJ disorders, grossly we can put them in 4 different categories. One is arthrogenous. In arthrogenous, there is a derangement of the condyle and disc complex. Whereas in myogenous, the disc position is in situ. So in both these conditions, there are some overlapping symptoms, like restricted mouth opening, referred pain. So these are the overlapping pain symptoms in arthrogenous TMDs and myogenous TMDs. The distinguishing feature between arthrogenous TMD and myogenous TMD will be that in arthrogenous, you generally tend to notice there is some kind of deviation or deflection, clicking. It could be either subtle or really loud. And other than these two, we have dislocations and subluxations, which are relatively easily to understand. And the inflammatory disorders, where you have a lot of joint inflammation leading to symptom complexes. So when we look at the TMDs, we need to understand why it is and what is the reason for it. And we need to strategize 2 things. We need to look at short-term outcomes and long-term outcomes. In terms of short-term outcomes, we need to look at relieving pain immediately. The patient has come to us, so our basic requirement is to make sure that patient is relieved from pain. Long-term outcome is the relief from pain needs to be sustained. Eventually, we are looking at improvement of quality of life. And by clinical experience, we all know that all these TMD-related pain conditions are sort of chronic conditions. Sometimes they resolve spontaneously, sometimes they bother you for a long time. So when we look at TMD disorders, we are looking at a symptom complex. It could be starting from a stiff or a locked jaw. The bite could be uncomfortable. There might be popping or grating noises, pain from jaw, related symptoms, pain and pressure and ringing in the ears. There could be pain in neck and shoulders, and chronic headaches. Now, from my experience, I can tell you that in the initial Etiopathogenesis, the symptoms are sort of restricted to jaw pain, uncomfortable bite, then some kind of stiffness in the jaw movement. But as the disease progresses, the supporting musculature comes into picture and all the associated symptoms start. And the kind of pain what we are having in TM disorders are kind of mixed pain disorders. And to quote from Dr. Ruchika's presentation, the axis 2 component, which we generally tend to ignore, should be considered in patient management. So the pain mechanisms in TMD, so we have the pathophysiologic phenomenon where we have the central sensitization of pain. Then there is also impairment of the descending pain inhibitory system, as well as neuronal convergence. Dr. Ruchika has very elaborately mentioned about the neuronal convergence, so we'll not go much into it. And apart from that, there are molecular level mechanisms where we have the N-methyl dasparate receptor activations, or the GABA and the glycine receptors inhibition. The kind of signature problem in TMD disorders are all these pains are self-maintaining. It's like a key. How much ever you try to unwind it, it keeps winding, and there is a sustained pain mechanism. There is no relief, and it kinds of provokes the next episodes of pain. And the clinical manifestations of all this pain could be from simple allodynia to hyperalgesia and temporal summations. Then we have sensory after effects, as well as referral pain, that the pain spreads out. It just not localizing itself to the joint. It starts spreading, involves the masticatory muscles, the supporting muscles, then headaches, dizziness. And there are even reports where they say the blood flow to the brain is sort of restricted or disrupted. So all this have a kind of a mosaic pattern of presentations. You really don't know which is the major component, which is the minor component, but then they manifest together. So we need to really identify the overlapping symptoms and then decide whether it is an arthrogenous or myogenous, or it is just kind of referred pain. So when we look at the old school and the new school in terms of literature, we don't have demographic data much, but then looking at the addition of literature from all over the world, there is no country which has not reported of pain from TMDs. So I would put it at, it is a kind of global phenomenon. We don't have, certain ethnic people who are more prone or not prone. The earlier literature, the studies were on few ethnicities. So then they would say that, some people are more prone for disorders, then women are more prone. But of late, if you look at literature, this is sort of getting disproven. Then the association of comorbidities. Then we have sleep disorders. It could be obstructive sleep apneas or occlusal disturbances. Now here it is the hen or the egg phenomenon. We really don't know whether the occlusion has caused the TMD, or because of the TMD there is a change in the way the teeth come together. The sleep disturbance, is it because of the pain complex, or is it because of obstructive sleep apneas? Most of the studies that are happening of late are called sort of associative studies. So in associative studies, it is very difficult to give a conclusion saying that, obstructive sleep apnea is one of the causes for TMD. When you look at how the governmental agencies are accepting the recent advances, if you look at the insurance companies in the United States, they don't accept any of this newer diagnostic methods for the insurance scheme. The basic reason why they reject it is they say that there is no absolute evidence that because of obstructive sleep apnea you have TMD, or because of occlusal disturbances you develop TMD. So if the insurance companies are not accepting it and the scientific community is trying to conclude saying that this could be the reason, so there is a kind of trade-off. We really don't know why this is happening. And if you look at the National Institute of Health literature, they have one sentence saying that it is always best to treat less in terms of TMD. Then the other comorbidities is the psychosocial components. Here again, the axis 2 components, whether the axis 2 components cause the pain, or is it because of the TMD, the patient is going into depression and other things. Then there is some kind of research going into the genetic predispositions. So, there is some SNP gene. So they have found some association of SNP genes in patients suffering from TMD disorders. The best way to understand the TMD disorders is to understand the etiopathoanatomic understanding. This is what I would call it. When we look at the symptom complexes, it usually starts with a pain, then it progresses to a click, eventually ends up in a lock. And when we see patients in our practice, the picture what we see on the left, they have traveled a path which we really don't know, which is sort of obscured. They have suffered, they have been to many physicians. We really don't know what was the etiopathogenesis and how it started. When we look at TMDs, till to date, we cannot put our finger on a particular etiology and say this caused the problem. So we need to look at a holistic approach to treating these patients, and we need to understand how the joint physiology and anatomy works. So just to briefly share the points here, the first picture, picture A, is the association or the axis of the disc joint complex. It is in the occlusal position and the disc is in anatomical position. In disc displacement disorders, the displacement of the disc is represented in picture B. So here we have all the symptoms of click and lock. If it is a disc displacement with reduction, we will have a click. If it is a disc displacement without reduction, it is a lock. Eventually what happens is, if the disc does not get corrected to anatomical position, because of the physical wearing up, there will be a tear in the retrodiscal tissues, or the disc itself can get perforated, and eventually it leads into an osteoarthritis kind of presentation. So this will be the kind of natural progression of the disease. And generally when we discuss about disc displacement disorders, we only look at it as anterior disc displacement with reduction or without reduction, or we look at posterior disc displacement with or without reduction. But technically, when I observe, rotational disorders are also there. Now, I don't have documentary evidence to prove rotational disorders because it is very difficult to get an MRI done wherein we can check if there is a rotational disorder. Now, why I say there are rotational disorders is because the method of disease assessment I have developed over the years, I assess the muscle tone of the masticatory muscles, the cervical muscles, the spinal muscles, superior spinal muscles, suprascapular muscles. Now there is a pattern of muscle spasms. What I've observed is this pattern of muscle spasms are not the same in all patients. Variations in amount of mouth opening, variations in the kind of deviations, they have a different patterns. So by understanding the pattern of muscle spasms, I can kind of mentally visualize what could be the disc position in the patient. So this information I use to manually recapture the disc to anatomical position. And from my experience, I would like to quote, there is no single or superior method or technique available which can provide a complete solution for TMD. There are so many methods. Each of them can provide relief to patients. At the same time, these methods have not given any relief to patients. So we really cannot conclude, say, okay, there is one best method in treating these disorders. Now coming to the core topic, the imaging protocols. What we want to see. When the disease is affecting the joint, we'd like to know how the bone is, how the articular eminence is, how the condylar head, the fossa, the muscles related to the joint, the cartilage portion, the disc, the shape and position. The shape and position form a major input into deciding on the prognosis for this patient. When we look at the disc, when we look back at the anatomy, the disc is sort of wedged between the condylar head and the articular eminence. And we know that it is biconcave in shape. When we have a displaced disc, now there is no binding to this disc, there is no confirmatory boundaries to the disc by the condyle or the articular eminence. So the disc tends to deform. And this deformed disc can take any shape. And from my experience, there is no time limit saying that if the disc has been displaced for 1 month, the problem is more, or for 2 months it is more. So on a timeline, we cannot tell whether the disc shape will be displaced, will be deformed if it has been displaced for a longer duration. So I'll share with you more information on how the disc shape helps in deciding the treatment protocols. And the last component is the inflammatory component, the joint effusion. More joint effusion means there is more, some amount of autoimmune response rather than the physical disruption. In some patients, the physical disruption causes a lot of inflammatory component in the initial days, but then the body kind of manages the inflammatory component. But whenever there is a kind of autoimmune component to the inflammation, then the joint effusion persists. The other kind of imaging that is available for joint evaluation is the arthroscopy, wherein you have a direct vision into the joint, but I would not recommend that in all cases. So that leaves us with the conventional radiographs, ultrasounds, CBCT, MRI. The new kid on the block, T-scan and JVA. Technically, I have not studied much on T-scan and JVA, so I will not comment much on that. But with a limited exposure, what I have to T-scans and JVAs, I wouldn't generally recommend them for treating TMDs. Maybe to understand the occlusion, it can be used, but definitely they don't give us a definitive input on the TMDs. So that leaves us with the basic facilities what we can use in our practice, the conventional radiographs. These radiographs definitely give us a lot of inputs into the disease process. Then CBCT, I will not recommend for evaluating TMD, only if you are looking at autoimmune diseases where you have erosion of the bone, then we need to use CBCT. Otherwise, the best tool for understanding disc disorders would be MRI scans. That gives us a clear picture on the disc shape and position. So in the MRI scan, we have different protocols that are used for documenting the temporomandibular joint. So we have the proton density suppressed oblique sagittals, then proton density oblique sagittals, plain oblique sagittals, T1, then gradient oblique sagittals. When you look at all these pictures, any MRI evaluation for TMJ should have an oblique sagittal cut. If you take just sagittal cuts, you will not get the complete picture of the disc. Hence, we should always ask for oblique sections. The second thing is, when you look at all these four pictures, pictures 1 to 4, the differentiation between the different structures, as in the bone and the disc, is best appreciated in proton density images, the image 3. Okay, if you observe very clearly here, you see that there is you can appreciate the shape of the disc very well in image 3. Whereas 1, 2, and 4, it is not so evident, or it is not so clear. So the best section will be the proton density oblique sections, sagittal sections, for analyzing the disc shape and position. Now, picture A here is the MRI image of a normal disc. Okay, it has a nice biconcave shape, and it is nicely fitting in between the articular eminence and the condyle. Okay, picture B is the shape of the disc. If you see, it is not biconcave, whereas it is folded. And picture C is a flattened type. The variations in the disc shape deformity is not limited to 1, 2, 3, 4. It can take any shape. The degree of deformation or folding or bulging varies from patient to patient, as well as the severity at the point of time where we have taken the MRI scan. So the take-home message here for the imaging for disc disorders will be using an MRI, which is one of the best tools for understanding and treating the disorders. Now, when the other imaging options, what we have, we need to really look at the clinical problems, gauge it, then decide on what imaging protocol we need to do. For example, if you are looking at osteoarthritis, you are looking at disease progression. Other than the pain symptoms, you want to evaluate how the bone is flattened out. Then in these cases, the best thing would be to take a CBCT or a CT. Or if you are looking for how the disc is getting deformed over time, in these cases, we need to go for sequential MRIs. But all said and done, this will only help us to understand the severity or the progression, disease progression. But what really the patient is interested is getting relief to his problem. So when we look at the treatment options available, we can broadly classify them as pharmacologic, conservative, and invasive or irreversible methods. Pharmacologic, the usual topical and systemic analgesics. They manage the pain for a temporary period of time. Then we have cognitive behavioral therapies. Now, cognitive behavioral therapy as a definitive treatment for TMD, definitely no. So here it can be an adjunct, but not the main therapy for TMD. From the previous slides, what we have understood is the main reason for all the pain symptoms are the displaced disc. So if you want to find a permanent solution to the problem, we need to get the disc back. It has to be in situ. Once it gets there, it has to stay there. If we can achieve this, then we can find a permanent solution to the disc disorders. If not permanent, in-between method is to make sure at least a part of the disc, which is totally slipped out, comes in between the condyle and the articular eminence. So it shares the load, and further progression of the disease can be sort of reduced or arrested. So in this aspect, conservative methods are very useful. It could be physiotherapy, manual therapy, or occlusal splints. Now, occlusal splints have been the mainstay of treatment for ages. How this work is, when you give an occlusal splint, you are increasing the bite. That is, between the teeth, you are creating a gap, which in turn creates a gap in the joint. Now, the ligament, which is the retrodiscal tissue to the disc, the physiology of this ligament is to pull the disc back to position. So it keeps constantly trying to get the disc back to position. So these occlusal splints help in making or supporting the pulling action of the retrodiscal tissues. Manual therapy will be the best, provided you can master the method. Now, in my method, I follow the manual therapy. Now, manual therapy So whenever you're considering attempting to manipulate the joint, make sure that you're not going to harm the patient by the therapy itself. So in my treatment protocol, I have a 3-level treatment protocol. One is the preparation time. It's about 2 hours time, where I spend time understanding how the muscles are in spasm and how with each manipulation of the joint, the muscles relax. Once I've understood the physical position of the disc, which is intuitive, there is no objective measure to say, okay, I have found out the disc is so many millimeters away from the fossa, or it is rotated by 10 or 15 degrees or 5 degrees. It is an intuitive method where I'm sort of able to picture the position of the disc. The next part of the treatment will be to manually reduce the disc to position. It takes less than a minute. If the disc shape is not deformed and the retrodiscal ligaments are in good health, the disc will snap into position in just less than a minute time. Post the procedure, I usually ask for 10 days of home care, where the patients are requested not to open their mouth too wide. It is a method wherein you provide a time window for the retrodiscal tissues to heal, because all this time they were being compressed between the condyle and the fossa. So they're sort of inflamed. So you give rest to them, they heal beautifully. They are able to maintain the disc position. There are two pictures, what you see here. Both these two pictures, if you look at the before treatment, the top row pictures, the mouth opening is only 20 millimeters. Okay, so by logic, if you look at the movement of the condyle rotates over an axis, then translates. So the rotational movement of the condyle, the patient will be able to open anywhere between 15 to 20 to 3 millimeters. So in these patients, the rotational movement is happening, but the translation is not happening. Reduction.
Sorry for the connectivity issue. Please be online.
Hello, can you hear me, Dr. Shruti?
Yes, sir. We can hear you, sir.
Hello?
Hello, yes, sir. You are audible now, sir.
Okay, if I'm audible, we'll start again. I don't know where we lost this thing.
Okay, sir.
So this is another case. If you look at picture A, the mouth opening is about 20 to 23 millimeters. The event occurred when the patient tried eating pani puri. So after trying to eat pani puri, he came back and said, this has happened. So the initial assessment was there is a disc displacement, probably because he tried to open his mouth too wide. I had OPG taken for him. If you look at the OPG, in the right side, in the open mouth position, the condylar head has translated till the articular eminence. Whereas in the left side, you see the condylar head sitting inside the fossa. And from the clinical picture, you see here that the deviation is towards the left side. Okay, so the diagnosis here was unilateral disc displacement without reduction, and the displacement was on the left side. The treatment performed was a manual disc recapture procedure. With the initial procedure, I was able to increase the mouth opening from 25 to 35 millimeters, as you can notice in picture B. And at 10 days follow-up, once the inflammatory component in the joint had healed, the mouth opening was restored to full 40 millimeters. And it has been like that after that. Now this is case 2. Here, this is a TMJ open and close view. If you notice here in the open mouth, on the left side, the translation of the condyle has happened, whereas on the right side, the condyle has rotated in the fossa, but it has not translated. And in the closed mouth view here, if you notice the distance between the articular eminence and the condylar head, the gap in the joint is large, it is not uniform. Whereas on the left side, if you notice, the joint space is sort of uniform. So from the inputs here, we can sort of conclude that it is a disc displacement without reduction in the right TM joint. Okay. Now the same patient, we have done an MRI scan. So if you look at the MRI scan, picture A is the closed mouth. If you observe the shape of the disc, it is sort of flattened out. On the right side as well, the picture B, even here, the disc shape is flattened out. If you notice the shape of deformity of the disc in A and B, it is the same patient, but you look at the degree of deformity. In A, the deformity is more severe, it is more flattened, whereas B, the severity is lesser compared to A. In open mouth position, C is open mouth position, where you see the disc is sort of bulged out, whereas D, the disc is reduced to the anatomical position. So we have a reducing disc on one side and a non-reducing disc on the other side. So the pre-treatment mouth opening was only 25 millimeters. So it indicates that only rotational movement was happening. But post-treatment, it has increased to 35 mm. The conclusion that can be drawn is that we have sort of pushed the deformed disc partly into the joint between the condylar head and the eminence. So this way there is more freedom of movement, and the symptom wise there was relief from symptoms. The acute pain that the patient was experiencing because of the compression of the retrodiscal tissues was sort of relieved immediately. And post-treatment follow-up, the condition has not worsened. It has been 4 years I've treated this patient. He's maintaining the same mouth opening. It is not affecting his quality of life, nor it has worsened. So this is another case where there is a deformity of the disc. If you look at picture A, you have a double disc sign. Okay, very rarely we get a double disc sign in disc displacement disorders. There is actually no two discs here, but actually the pterygoid muscles, if it is inflamed, the insertion of the pterygoid muscles show up as an intensity similar to the disc. So this gives a double disc appearance. So here this is a displaced disc and it is deformed. When the patient tries to open the mouth, it is not reduced anatomically. The left side in the closed view, you also see that the disc is deformed, but then when you open, it is getting reduced. So it is a reducing disc with deformity on the left side. It is a non-reducing disc with deformity on the right side. Now, why I'm stressing this diagnosis here is, clinically we limit the diagnosis to displacement with or without reduction. But when we look at the MRI findings, we have an additional input of disc deformity. Now, this disc deformity helps us to decide the prognosis of the treatment outcomes. So I feel that post-investigation, we need to add another term into the diagnosis saying that it is a displacing disc with deformity or a displacing disc without deformity. So in this case also, the initial pre-treatment mouth opening was 25 millimeters. Post-opening, it has increased to 35 millimeters. In all the cases where I treat manually, if the disc is not deformed, mouth opening is restored completely. In case the disc is deformed, then establishing complete mouth opening is not possible. We have heard of posterior disc displacements. So this is one case where I could document on posterior disc displacement with reduction. Now this patient would have a kind of hypermobility of the joint. And it is not a kind of subluxation or dislocation. This was a kind of habitual movement of the patient from a very young age. And there would be a click while closing, the closing click kind of a presentation, but a really loud click. So when I got the MRI done, it showed a very nice posteriorly sitting disc and it used to get reduced. The displacement here, if you see, was only on the right, left side, whereas the right side, it was getting reduced. Whereas left side, it was a non-reducing. It was posterior disc displacement without reduction on the left side and disc displacement with reduction on the right side. I have flipped over the image on the right side just to associate or give you inputs on the symmetry with the OPG, what we have put here on open and close. This is another case of posterior disc displacement with reduction. Okay. Now this is an elderly gentleman. He says he was enjoying his New Year's Eve and just resting and watching TV. He was sort of semi-reclined position, and suddenly he realized that he is not able to close his mouth. So he came to me the very next day, and we did not do any extensive MRI scanning for this person. When he came to me, he had come with TMJ open and close view. So if you look at the views here, the open mouth, the right side, both the green dots, you see the condylar head is aligned with the articular eminence, means opening is perfect. In the closed view, the right side condyle is not seating fully into the fossa, and the left side is entirely outside the fossa. So based on this input, diagnose it as a posterior disc displacement without reduction. The symptom what he had was he was not able to get his teeth together. So in my manual method of repositioning, I did attempt, but I was not successful in the first attempt. So the first sitting, I could partially reduce the disc. Then we did a second sitting after 3 days, and I was able to completely reduce the disc to anatomical positions. Post-treatment, it has been uneventful, and he's been comfortably chewing, opening, and he says he can even eat non-veg with the kind of problem he had now. He's comfortable even with eating non-veg food. Now, there are sometimes pathologies which have a TMD-like presentation, but actually there is something very more serious happening there. So I will share 2 such cases with you here. See, this patient, she came to us with presentation of inability to open the mouth. So clinical examination, it looked as if it is a non-reducing disc on both the sides. When I attempted to reposition the disc after trying to relax the muscles, the mouth opening, there was not much improvement. We could just move from 22 millimeters to 24 or 25 millimeters. So the improvement was only about 3 or 4 millimeters, which was very surprising because most of the patients have been able to reduce without an issue. So here in this patient, when the history was being taken, she said she would repeatedly get injured when she was carrying her child would bang his head into her face. If you look at the area here, you can see there's a swelling next to the nasolabial fold below the eye. So by history, she said, very recently, there was one episode where the child hit her face with the head. So it was very, now not able to put my finger what the problem is, but then we assume that it is just a simple disc displacement. When in spite of trying to reduce the disc, I was not able to do it. We thought of examining further and we got an MRI scan done for this lady. To my surprise, there was a tumor in the pterygoid fossa, and there were 2 lesions, one in the pterygoid fossa and one in the anterior region, infraorbital region. So this was actually a surprise for me. So this is one such case where the clinical presentation was like a TMD, but then there was a really serious problem. Now the presentation of the tumor here, we missed out in the OPG. OPG was looking very normal. So hence, sometimes if the treatment is not successful, I think we should explore the availability of MRI and then look into the reasons for why the treatment is not successful if required. Similarly, if we look at second case here, this was actually, we had some clue on the OPG here, the open-close views. The right open and closed views, if you see, the open view also had the condyle comfortably sitting in the fossa. And the left side, irrespective whether open or closed view, the condyle was always in line with the articular eminence. It was not going back. And the gap between the condylar and the articular fossa was huge. It was not that the reduced disc can occupy so much space here. So when we did a scan for this person, we found a huge tumor pressing into the pterygomandibular fossa, and then it was pushing the left condyle anteriorly, because of which it presented as a TMD rather than a tumor. This is a very interesting case. A school child about 7-8 years old. When mother used to feed this child, she was not opening her mouth really wide. So the mother would get irritated thinking that the child is not opening the mouth and she doesn't like to eat. Then when this happened repeatedly over a period of few months, the parents realized that there is something wrong with the kid, that she's not opening her mouth wide. So when they got her to me, I realized that it is a disc disorder. Then what was bothering me was disc disorders, displacement disorders in such young age is extremely rare. So I started talking to this child to understand how it might have happened. Eventually, I realized that it was because of the water bottle what she was using. These sports water bottles have a pull-up tap. So you need to pull up the cap and then the water will pour out of it. So this child was using this kind of a water bottle to pull the cap with the teeth. So for doing this procedure, she would bring her jaw anteriorly so that the groove of the cap would come between the incisal edges and she would pull it. So probably in one such event, the disc has got displaced and it was displaced bilaterally. I was able to reduce it and restore the mouth opening to the complete 30 millimeters for this child. Now, during preparation of this presentation, I got a few questions from the organizers. The questions were raised by the participants. So question 2 was the scope of opening pain clinics. I think Dr. Sood has given a lot of inputs on that, so we'll not go into that much. But then I will share my experience of being an exclusive orofacial oral medicine treatment clinic. And regarding question 1, this question, it says, is there any variation in cerebral blood flow circulation for a patient having TMD, and also while the patient is using occlusal splints? To answer this question, I will share a case which I treated very recently. So it was actually a blessing in disguise that this question came up with the audience. Question 3 and 4 I've sort of answered in my presentation. So we will come to the other questions. Now, what clinical symptoms can suggest that there is a cerebral blood flow variations in TMD? Okay. Dizziness is one major input where we can say that the TMD has caused a cerebral flow disruption. Headache is another symptom. Okay. How can we say that these two are a reason for the symptom is the TMD? Is when we reduce or resolve with corrective positioning of the jaw, the symptoms resolve. To support my claim, there is a publication here which says the physiologic rest position of the mandible might have an effect on balance by showing a trend, a tendency in enhancing cerebral blood flow as measured by transcranial Doppler. So this is a 2015 publication where they have kind of given us an input saying that a change in the mandibular position can have an effect on the way the blood flows to the brain. Now this case from my practice, this is a middle-aged lady. She's a professional, a lawyer. She would complain of stiffness in her jaw and associated headache with dizziness for a few months. The dizziness was so severe that her head would lean towards one side And at times she would walk into her colleagues because she could not balance herself. This was kind of very embarrassing for her. Now she visited another care provider who has this T-scan facility. He did a scan for her, and he has given these readings for her. My apologies, I cannot read what is happening in this because I'm not well read with this. But what I understand is that she was told that there is a balance with, there is an imbalance with the occlusion on the right side. And the treatment suggested to her was a full mouth rehab, where the dentist wanted to provide an occlusal rehabilitation so that the whatever reasoning is there, it could resolve the symptoms of the patient. And when the patient asked the dentist, is this successful? Can you tell me how successful this method is going to be? He said, I'm going to only try and attempt, but whether it is going to be successful or not, I cannot guarantee you. So the question that came to patient's mind was, when I'm going through all this, I'm spending so much time, and an irreversible method is being suggested to me. Is it really worthwhile attempting to get the treatment done? So with these questions in mind, she visited me. So I told her I'll try to help her out. And I told her my method of treatment. She was initially skeptical, but then she said, okay, I will give it a try. So the initial pre-treatment mouth opening was about 30 millimeters. After manipulation, the mouth opening improved to about 36 millimeters. Now, when we look at the range of movement, we say that the range of movement is about 40 millimeters would be in the median range of movement, or an average range of movement. In this patient, we have not reached there, but then the patient has a small face. And then criteria other than the scale what I use is 3-finger width of the non-dominant hand going between the incisors, gives a sort of rough indication that the mouth opening has been achieved to the normal range. So in this patient, we were able to get her 3 fingers between the upper and lower teeth. So with the assumption that we have reached the full range of movement. What is interesting is, after I did the treatment on 19 September, so I just told her, you just keep me posted on how you are doing. I will share with you the screenshots of the WhatsApp conversations I had with her. Okay. So the first message I got from her was on 21st September, where she said, only thanks for the treatment. 22nd, she says, I don't have dizziness, but when I speak and eat, little pain near the joint. I am staying at home and not talking much. This is for your updates. Then suddenly on 23rd, I get another update saying that, sorry to bother you. I had dizziness the whole night and I couldn't sleep. But then she didn't have dizziness in the day. And she was also positive that, the treatment is going to help her and she will recover. I just reassured her and said, nothing to worry, she'll be fine. And generally after the treatment, I dispense medicine which I formulate myself. So I just asked her to apply that over her shoulders and neck and breast. And then 26, she said, everything is fine. I'm getting my massage done. And she actually called and said, all is good. So after I got the question from the audience regarding the dizziness and how the cerebral blood flow is affected by TMD, I got back to her and just asked her permission to share the T scans and other things. And I also asked her an update. The latest update was yesterday. She said she's doing good. And then she has also taken some X-ray and an MRI for the brain scan, because she was worried that there might be something wrong in the brain. and how a treatment to the TM joint can affect the brain scan. So I kind of reassured her that if my treatment doesn't work, then you go for a brain scan. Then when I had a conversation with her, she said, I'm good, but then in the back of my mind, I just wanted to get it cleared that there is nothing wrong in my brain. So she has got an MRI scan from the doctor and she has met a neurologist. And then she said, all is well. This is another case with similar symptoms. Dizziness, discomfort around the joint. So middle-aged male is a teacher by profession. If you look at the pre-treatment, you see the mouth opening is 45 millimeters. So the assumption here for me was there is a full range of movement. There was no deviation, there was no deflection, but all the other symptoms of TMD causing dizziness, discomfort over the joint, the cervical muscle spasms, the suprascapular trapezius spasms. So clinical examination, there was all telltale information saying that there is a TMD. But what was not matching was the full range of movement. To my surprise, I treated this patient just like any other patient as TMD and did a manual disc recapture procedure. You see the mouth opening. It is 50 millimeters plus. Okay. So if we had really gone by the indicator of the natural range of movement for this patient, he is already in the upper range in the pre-treatment picture. So we would have missed the presence of TMD and probably would have thought of other pathologies and started treating him otherwise. So this case is kind of important to me to share with you, is that the signs and symptoms of TMD are just not related to the joint itself, but there are other signs in the muscles which are supportive to the TMD. So if you all develop a skill of assessing the muscles, not only the masticatory muscles, but whereas the cervical muscles, the trapezius, and the supraspinal muscles, you will be able to assess if the pain symptom complex could be because from TMD. To support this claim, there's another case I would like to show here. Even here, this is an elderly male, retired, similar complaints. Pain on both the sides, headache. The range of mouth opening is normal, 45. Okay. But if you carefully observe his neck, you see that the corner, the picture you can see in the corner, the neck muscles are straining here to keep the mouth open at 40 millimeters. So this was an indicator for me that this is definitely a TMD. And post-treatment, if you see here, the mouth opening was 50 millimeters, more than the average range of mouth opening. So these kind of cases where the range of movement is actually more, and post-restriction, they are in the average range of mouth opening. In these cases, there is possible that we can look away from TMD as a source of pain. So this is one takeaway point I wanted to share with all of you. So now things to keep in mind with treating TMJ disorders. The clinical examination provides the maximum data, not only for diagnosis, but also for taking a call on prognosis. The next thing important is you need to communicate with the patient. They're in pain. They will not understand the technical jargon. You need to keep it in plain, simple language. Assure them that what has happened is not very big disease. It can be managed. Don't give them false hope that will be cured, because we don't know how these pain symptom complexes work out when we start treating them. But help them with the notion that it can be managed, nothing to be worried about. And always try your level best for a conservative approach. Now, there is no one best method available. This is a drawback in the present scenario. So a conservative approach will always help, so that you're not doing anything irreversible. Suppose you have provided full mouth rehab with all crowns. Then later you realize, okay, that is not solving the purpose. Your intention was to help the patient, but the treatment what you have provided has not helped the patient, and we have irreversibly done damage to the dentition. So before taking any treatment decisions on providing irreversible treatments, please make sure, take the patient into confidence. Only if you're doubly sure, you attempt it. Otherwise, always try to follow a conservative approach. So we'll wrap up with that, and thank you for attending this program. In case you want to get in touch with me, this is my email and my phone number.
Thank you, sir. That was a very informative session, and thank you for addressing the questions also. We have some additional questions. What is the procedure for manual disc recapture technique?
I'm sorry, I can't hear what you're speaking.
Okay. So can you hear now? So am I audible now?
I'm really sorry, I can't hear anything what you're speaking.
So is it audible now?
Just hold on, just hold on. Yeah, you can speak, madam. Tell me.
Okay. So thank you for answering those questions already, but we have some other questions. First one is, what is the procedure for manual disc recapture technique?
Yeah, tell me now. Yeah.
Procedure for manual disc recapture technique.
You can speak, madam. Okay. See now, the procedure I have not explained or shown intentionally here because it is very technique sensitive and requires very fine movement of the mandible. Okay. It is very similar to how you displace the well-pushed extended joint, but the movements are very subtle, very fine, very balanced. So this is the method which I have developed on my own. So unless really can appreciate how the muscles are responding to this method of treatment is very difficult to emulate or copy.
So we have one more question. Fellowship program for CNG arthroscopy in India.
Sorry, I can't hear you. There is a lag in your.
fellowship program for TMJ arthroscopy?
A lot of lag in what you speak and what I hear. Let me just log out and get back to you. Okay, just hold on.
Okay, okay, okay.
Hi, can you hear me now?
Yes, sir. Yes, sir. You're audible now.
Okay, tell me.
So the question was, what about fellowship programs for TMJ arthroscopy in India?
See, I really have no information on arthroscopic procedures or the fellowships. Probably if you can hook up with some oral surgeons who are doing it, that will give you more inputs.
Okay, thank you.
And
sir.
I am actually not a big fan of arthroscopy because the patients whom I've treated who have undergone arthroscopic procedures, in them the prognosis have been very poor. So probably if they had got the manual recapture procedure done before attempting arthroscopy, maybe the prognosis would have been better. But since we don't have any evidence of case control studies here, I'm just speaking out of experience that disruptive procedures, invasive procedures, to the extent possible should be avoided, because arthroscopy you're only going to do a lavage of your joint. You're not trying to physically reposition the displaced disc. So I really don't know how effective these methods are because I've not done them, nor I have any follow-up information of patients who have got treatment with arthroscopic procedures.
Thank you, sir. Thank you for a very informative session. We will now break for lunch and reconvene at 2 p.m. for the afternoon session. Thank you, everyone. Good afternoon, everyone. We will now commence with the third talk of the day by Dr. Suhas on the topic Trigeminal neuralgia, diagnosis and medical management, strategies for general dentists. I request the delegates to type in your questions in the chat box and we will discuss them at the end of the session. Over to you, Dr. Suhas.
Hi, good afternoon. Hope you had a nice lunch. So, time to wake up. Now, these quotes, what you see here, if you start sharing these quotes with the patient who visits you, what's going to happen? He's really going to think that whether you're really a doctor or you're trying to fool him. When we look at pain conditions, these pain codes have absolutely no bearing on the patient suffering, and these pain codes look fantastic, fantabulous only in poetic languages. But in reality, we know what these patients go through. So in this presentation, we'll do a brief on the disease. Then we'll shift to practical tips for management. And then we'll also look at how to do or how to manage these patients using single drug management. Okay. Now this presentation is for the purpose of general dentists. So we're really not going to go into the extensive methods of management, but then we are looking at a comprehensive process wherein even with very little skills, one should be able to manage patients, document the pains, and then the dentist can really decide on when to refer the patient to the oral physician. And then we'll take up the question answer sessions. In briefly, the anatomy. Trigeminal nerve is your sensory nerve to the face, having 3 branches, the ophthalmic, maxillary, and mandibular. Why this is important is the pain condition what we are discussing now is associated with either one of the branches or more than one of the branches. This is important to localize the trigger areas and to decide which branch is actually causing the problem. Hence, we should be aware. Then the general background of this disease, when we look at, this is basically an agonizing disease. And when we look at natural progression of disease, there is always a chance of natural remission. And the duration taken for remission varies between months to years. But the very few months or weeks the patient suffers, the agonies are so severe that patients many times feel like ending their life because the pain episodes are so severe. Another problem with this disease is between the episodes of pain, the patient is absolutely comfortable, but then is always under the fear of the next possible episode. So when we look at the etiopathogenesis, it is basically to understand there is misfiring of the trigeminal nerve. Okay, to give a layman analogy, this is what I use to help the patients understand. What I tell them is the electric supply what we have in our sockets at home or offices is a 240 volt supply. Just imagine in a 240 volt supply, suddenly there is a surge for 1000 or 2000 volts. What is going to happen to the connection? So the patients then they relate to the problem. Okay, so I tried to tell them that constantly there is a small amount of current running through the nerves for everybody. Then suddenly there is a surge of activity because of which you are experiencing pain. This explanation, usually the patient understands what is happening with him. Otherwise, they're on the constant fear that there is something seriously wrong. They even think that there must be cancer and other serious illnesses. And they fear that the quality of life is going to suffer because as days progresses, this condition worsens. Okay, so basically these misfirings happen because of the sodium gate channels in the nerves. And the latest concept is that they are channelopathies. Okay, now channelopathies are a different understanding of the disease process, wherein the concept here is the trigger points to the trigeminal nerve, there is a single channel. That is the reason only certain areas of the mucosa develop trigger points. So that is the hypothesis of channelopathies, but basically it is something related to the electrical impulse transmission at the sodium ions in the nerves. So when we look at the causes, 3 different causes are there. Why we need to understand the three different causes is because the treatment process what we are going to look at is going to vary from first, second, and third. Majority of the patients who are suffering from this disease, the cause is idiopathic, means we really don't know what is causing the electrical imbalance in the nerve. The next group is called as classical trigeminal neuralgia. We call it classical because the ganglion, the trigeminal ganglion, sometimes is having a compression from the basilar arteries surrounding the ganglion. So this is because of vascular compression. Now the question we need to ask here is that basilar artery was lying around the ganglion from the time the patient has been born and the way the nervous system developed. It is not that overnight it came and it positioned itself around the ganglion. When you look at literature, symptomatic neuralgias in vascular compressions, that is the proximity of the basilar artery to the ganglion, if you see, only few patients develop pain. Okay, so if there are say there is about a 24% incidence of symptoms in patients who have proximity of basilar artery to ganglion, whereas the other way around, patients with trigeminal neuralgia, the classical variety, about 60 to 70% have vascular compression. So the statistics here really don't match up to say that all vascular proximities can induce pain. The last group is known as the secondary trigeminal neuralgia. Here we have some other disease which causes sort of demyelination of the nerve or compression, resulting in symptoms. They could be cerebellopontine angle tumors or multiple sclerosis or trauma. So the requirement to put the patient into one of these is important for our disease management. When we look at the compression aspect, if you see, this is a pictorial or graphical representation of the proximity of the nerve with the basilar artery. It is naturally in that position, but then in some patients, it develops a pain symptom complex, probably because as age advances, maybe the vessels become more flaccid and then they press on the nerve. What gives evidence is that in these cases, surgical procedures to decompress relieve patients from pain. So there is evidence that the compression is the reason that is causing the pain. So now we'll come at, now that we have gone through the understanding of the disease basics, we'll look at the practical tips for managing patients suffering from trigeminal neuralgia. Now here, I put it as 1 + 6 challenges. Okay. The 6 challenges are one group. The one, totally 7 challenges. The one challenge, the 1+ challenge, that is the additional challenge, it is like grade A+, 1+, is the most crucial in managing these patients. Okay. So first we'll look at the 6 challenges. Then we'll go to the 1+ challenge. So here, the first expectation, the challenge here is patient expectation. Now, generally, when we look at patients, these patients who have neuralgic pains, they have absolutely no idea that these are chronic pains. So what they are expecting is complete resolution of pain. It is very similar to the discomfort or pain symptoms they have when they have other diseases. So where they pop in analgesics for 3 days, 5 days, then their pain symptoms vanish. So the expectation is that we need to really educate the patient on the chronicity of the problem. The next challenge is pain pattern identification. So when we look at the pain symptom complex in neuralgia and the other orofacial pain conditions, it is extremely essential to identify the pain pattern which indicates that this could be trigeminal neuralgia. Then based on the symptom complex, which are positive indicators, we look at the diagnosis, that is the next challenge. Once we diagnose, then we really need to ascertain whether our diagnosis is correct or wrong. So challenge number 4 will be confirmation of diagnosis. Once we confirm the diagnosis, the next challenge is the medicine, what we prescribe, how we are going to prescribe, how much to prescribe, what instructions you tell the patient. And the last challenge is follow-up. Here, if in the challenge 1, the patient expectation, if you have not educated him on the chronicity of the problem, he is going to follow the same thing what he has done before he has reached you. Your medicine is not curing him, so he will go to the next dentist or next healthcare provider. So if you want to have a continuous follow-up with him, you need to really educate the patient saying that it's a chronic problem. It is something like sugar or hypertension, where the pain problem is going to last for a long time. And then we can manage the pain. And the hope what the patient should be given is the possibility of a spontaneous remission. If you look at the natural history of disease from literature as well as personal experience, the disease goes into spontaneous remissions many a time, sometimes in weeks at a time. But some patients, unfortunately, hangs around for months or years together. The last challenge is the agony management. Okay. So here, compared to other pains, these pains are agonizing, severe. Even though they last for a few seconds, patients feel that it has lasted forever. And the severity of the pain, if you can imagine, the pain strikes on the face and then travels all the way to your trigeminal nerve. So the experience of pain is so bad. Many of them, majority of them, I will say, are looking at ways of ending their life, committing suicide, because the pain is intolerable. Some people express it in the first visit itself. Some people express it in the later visits. But the agony of the pain which the patient undergoes needs to be understood, and we need to empathize with the patient. Otherwise, the treatment protocol successes will be very minimal. When we look at literature, the neuralgia is more common than what the literature says. Now, because I have an exclusive oral medicine practice, I get referrals from many general dental practitioners, and believe it or not, 6 to 8 adult patients add up to my patient list every month. Okay, some are from the college, some are from my practice, but on an average, 6 to 8 patients add up to my patient list every month. Till date, I have about 45 neuralgia patients following up with me in my clinic in Bangalore. So I know how these patients go through the pain and the kind of support as a healthcare person we need to provide to these patients. Now, coming back to the challenges, the diagnosis from symptoms. 6+1 here again. 1, this pain is sudden, paroxysmal. It is intense. It is one-sided, electric shock-like pain, lasts for few seconds to minutes, and between episodes of pain, the patient is absolutely free of pain, but lives in the fear that he is going to experience the next episode anytime. The last point is the triggers. Okay, so there are trigger points, sometimes in the mucosa, sometimes in the face. So even the smallest touch or non-painful stimuli can initiate intense pain in these patients. Okay, so these are called as trigger points in the trigeminal neuralgia. The next challenge for us is confirmation of diagnosis. Now, based on symptoms, we have diagnosed the patient to be suffering from neuralgia. So how do we confirm that this patient is definitely suffering from neuralgia? 2 things we can do. One thing is we have identified the trigger points. We can use a local anesthetic into the trigger points. It could be a topical anesthetic spray or an infiltration injection, and wait for the symptoms to subside following medication, and observe the patient if the repeated episodes what is getting reduces. If it happens, then we are bang sure that it is neuralgia. Sometimes what happens is, as I told you, the new concept of channelopathies. So here we say that trigger point what is identified by the patient we have used for local anesthetic. But there is a possibility that there are other areas where the trigger points are not there, but still they act as a conduit for pain sensation. So in these cases, we can use carbamazepine. Okay, as a stat dose, we can use a suspension of 100 milligrams in 5 ml. If our diagnosis is correct, carbamazepine will subside all the electrical activity that is surging, and the patient will experience comfort in about 45 minutes to 1 hour time. If suspension is not available, we can always have tablets in the clinic or department. So you give 1 tablet of 100 milligrams, make him sit in the waiting area, observe him for about an hour. If the pain subsides, he feels comfortable, then we are pretty sure that it is trigeminal neuralgia. So these are the tips where you can confirm the diagnosis of trigeminal neuralgia. The next challenge is the pain pattern recognition. This is the key to have a successful treatment strategy. The more time you spend on observing the pain pattern and analyzing it, the easier it is to treat this patient. So what do we record in this pain pattern? We are going to record the timing, in the sense at what time of the day the episode happened, and during the episode what was the intensity of pain, and the number of episodes the patient experiences in one particular day. By using data from this, we will be able to design the treatment protocol for these patients. Now, this is the pain monitoring diary which I use at my clinic. This is available on my clinic website. The link is there on the bottom of the screen. It is free for download. If any of you want, you can download and then use it very freely. So here I have grouped the pain diary into weekdays, Sunday to Saturday. Is to record the time at which he or she experiences the pain and the intensity score. Now, this intensity score can either be recorded by the patient or by the caregiver. The right bottom corner of the page, there is a visual analog scale which gives numbers from 0 to 10. So we need to educate the patient how to use the number scale. Who were in the morning session. Understand to write the numbers. Another dilemma what these patients face while recording the pain diary is scoring, whether to give score 4 or 5. As we know, it is very subjective. So we need to tell them, in case you have a dilemma, whether the pain is 4 or 5, ask them to note down the higher scale. Okay, so that way we are really not missing the patient experience there. The next challenge for us is to analyze this data. Now I will share with you the data from one of my patients. This is from the last month data from 12th September to 24th September. Okay. The x-axis is the time at which the patient experienced the episodes of pain, is the x-axis. And the y-axis is the intensity scale, 0 to 10 scale. If you see the clustering of pain episodes, you observe that most of the pain clusters are in the morning 6 to 8 time. Then there are some episodes in the afternoon, extending up till late afternoon. But when you look at the evening episodes of pain, very sporadic events of pain, and sometimes minimal, sometimes mediocre. There's one outlier episode where the intensity is 8. Okay. Now, this patient, this is the first visit data what I'm showing to you. So in the first visit, what I've given is, I've given them 200 milligrams of Tegretol, carbamazepine, in extended release manner. The timing of the dose is at 12 hours interval. So morning 8 and evening 8 is the dosage what I've told them. So with 1 week, I see that the pattern accumulation in the early morning time. So next challenge is for me to make these patients pain-free in the morning period. So when the 7 a.m. is the time when they're experiencing pain. So what I tell them is to get up early morning, 4:30, 5 o'clock, use an alarm, get up, drink some milk or eat some biscuit, then take your first dose of medicine, say at 5 o'clock. When I do this, by the time they get up at 7 a.m., the medicine is acting and this cluster of pain episodes which have been occurring at morning 7 o'clock subside substantially. So this is the trick in identifying the pain pattern and timing of the medicine. When we look at any pain management, here the patient is an active participant in their own care. Okay, so it's a game of chess here. The chess game here is between choosing the medication, the dose, as well as patient compliance. You might have chosen the best drug, given the best regime, but if the patient is not compliant, then he is going to come back with you with experiences of pain episodes. So it is very important that during the follow-up, you need to make sure that the patient had taken medicines on time. Sometimes they say, oh no, doctor, I missed on 1 or 2 days. The next day the pain increases. So when this is the presentation, you should ignore those spikes or breakthrough pain. Otherwise, you know that the pattern of your prescription is working well for the patient. Now here, today we'll be discussing single drug approach. Okay, there are other medicines which can be used for managing trigeminal neuralgia, but since this is designed for general dentists, not specialist thing, we will limit to the single drug approach. And carbamazepine is the gold standard. Okay, even if the patient approaches a neurologist, he is going to start with carbamazepine as the initial line of treatment. So by experience as well as by literature, carbamazepine is the best treated medicine used for managing neuralgia. It works by blocking voltage sensitive sodium and calcium channels. Okay, so that is in brief the working of this molecule. Next is this trivia I should understand. Okay, the therapeutic levels required for managing neuralgic pain is 4 to 12 micrograms per ml. This is the levels that should be present in your blood for the medicine to have some therapeutic effect. Okay. Now carbamazepine is available in 3 forms. One is a suspension, one is a tablet, and other is an extended release. Okay. When we take tablets, the peak therapeutic levels are achieved in 4 hours. And extended release, it takes about 12 hours to reach this peak plasma levels. This is important for us because when I discussed with you the timing of medication, we need to take this into consideration while deciding the time at which you want to prime the system. Okay. Now, this is the most important sentence which you need to remember when you are using carbamazepine. I'll read it out for you. Plasma levels of carbamazepine are variable and may range from 0.5 to 25 microgram per milliliter. The next part of the sentence is important. With no apparent relationship to daily intake of the drug. Okay, you might have given the patient 1200 milligrams in a day, but that has no bearing on the variability of plasma levels. Okay, from person to person it can vary anywhere between 0.5 to 25 micrograms per ml. And if we go back to the previous slide, therapeutic levels required are 4 to 12 micrograms per milliliter. Now, response to medication when we look at and resolution of symptoms. This by and far all people who have managed neuralgia patients will be able to appreciate what I'm telling. The initial response is excellent. Patient is happy, 1 month, 2 months, no problems. Then as days advance, the response to medicine reduces. The scientific reason for this is the half-life of Tegretol or carbamazepine. The initial half-life values, that is the initial duration, what medicine you give, the first few months, the first time you are giving this medicine to patient, the half-life values range 25 to 65 hours. So the medicine, one dose what you have given now is in the therapeutic range level for almost a day or more than a day, sometimes up to 3 days, 4 days. So what is happening is, intentionally or unintentionally, you are peaking the plasma concentrations and making sure that those triggers of pain are managed by the availability of medicine. But as time advances, because of how the body manages the molecule, the half-life reduces to 12 to 17 hours. So the body knows I'm getting this molecule more frequently. So initially the metabolism is delayed, but as and when you start loading the body knows that this is one product or molecule which the body is receiving repeatedly, and it develops a mechanism to metabolize it. So initially more time it was taking, now the same dosage, it metabolizes faster. So this is one reason why the therapies fade out to make a impact on the patient's pain control as time advances. The next problem is, because if you are increasing the dose, any molecule what we use for treatment, there is the intended purpose for which it works and the other effects. The other effects is what bothers us here. We want the pain to go away. At the same time, when we increase the dosage, the patient is going to experience extreme drowsiness. Drowsiness is very important to be managed, especially in elderly patients. Just imagine the elderly patients whom you are taking care of. You have primed them with almost high doses of carbamazepine, and they need to get up late night to use the restroom. They are drowsy, they are not able to orient themselves. The possibility of a fall and further damage ensuing the fall is more serious than living with neuralgia. So you need to really educate the patient on the concept of drowsiness. You need to tell them that we need to strike a balance between drowsiness and your pain experiences. Caution them initially till we titrate the doses to the required values. They will be experiencing drowsiness. So we can start with 200 milligrams per day, gradually extend it to 400 or 600 milligrams, depending on how the patient is responding. The 600 milligrams per day dose, what I mentioned, is not the upper limit. But then for general dental practitioners, they should keep this as the upper limit. And in case the patients are not responding to this level, they should consider immediately to refer the patient to either oral medicine specialist or a neurologist. Now, there is always some amount of breakthrough pain. Breakthrough pains are the most difficult to handle because you have been treating the patient, they are being very comfortable with their pain symptoms. Suddenly they experience a couple of bouts of pain so severe that they start getting disappointed, saying that the problem has aggravated again. Now, why the breakthrough pain occurs is very difficult to explain, because the patient is responding well to medicine, he is pain-free throughout the day, but some days there is a breakthrough pain. So these kind of pain episodes we need to manage and can be efficiently managed by using the suspension form of carbamazepine. You can give 5 ml of suspension, which is equivalent to 100 milligrams dosage. The advantage of using suspension for breakthrough pain is it reaches peak concentrations in half an hour, 45 minutes. So when patient is experiencing such episodes, this will definitely help him in managing the breakthrough pains. When we come to investigations for neuralgia, 2 investigations are a must. The MRI scan for the brain. This is important because if you can recollect from the initial slides of the classification of the disease, we have idiopathic, classical, as well as secondary. In the idiopathic, the MRI will be normal. Whereas in classical, we will have an abutting artery to the ganglion. And if it is secondary neuralgia, we have some kind of tumor in the cerebellopontine angle, or it could be multiple sclerosis, things like that. So MRI will give us a definitive indication into which category it forms. So if it is idiopathic, then as a dentist, you can manage very comfortably because you know that there is nothing serious happening there. And you can manage by titrating the dose. But if it is classical, where there is a compression of the nerve by the basilar artery, and by evidence, we note that the pressure, if it is relieved, patients experience relief from pain for a long duration, up to many years. And then it comes back later in some cases. So the patient should be given an option of a surgical option. So this MRI scan will help us with that. If it is secondary trigeminal neuralgia, definitely MRI will give us the definitive input, and we can always refer the patient to a neurosurgeon. The next investigation we need to consider for patients to whom you are prescribing medicines is the WBC differential count, because long term when we use carbamazepine, that causes agranulocytosis. So just to keep a tab on the possible agranulocytosis, we need to get this investigation done. The last question was when and whom to refer. Okay, so considering that we are talking to a group of general dentists, if the patient is non-responsive with up to 600 mg per day dosage, refer the patient to a oral medicine consultant. Okay, and these were the 2 questions related to neuralgia which were shared to me by the organizers. One was the scope of opening the pain clinics. It is a fantastic opportunity. We'll need to consider that. And I have been practicing exclusive oral medicine practice, just not pain clinic. It is exclusive oral medicine practice. I manage mucosal lesions, pain conditions, and TMD. And I use a sort of holistic approach. It is just not allopathic medicine I use Ayurvedic preparations as well. So far, the response to the private practice has been good. But if you look at it as a career in terms of monetary aspects, not very fulfilling. You definitely cannot manage your family life and other commitments with just oral medicine practice. You need to make a few RCTs as well. Now, coming back to the second question, the recent advances in neuralgic pain management. If you scan the entire literature, we have medical and surgical techniques. Okay, in the surgical techniques, we have microvascular decompression and other destructive neurosurgical techniques. The indication for these, for example, microvascular decompression, is valid only if there is evidence that the artery is abutting the ganglion. Okay, but other neurosurgical techniques which cause destruction of the nerve, here what happens is the effect is not permanent. Sometimes they come back. Second thing is the side effect of this. The patient is going to have an anesthetic feeling because you have demyelinated the nerve by the destructive procedures. So those surgical procedures should be used as second line if the medical line fails. And when we come to medical line, there are many molecules which have been tried, including local anesthetics, but then there is no absolute evidence that these newer methods work. Another problem why we are not able to conclude or develop newer molecules or methods is the ethical issues. We cannot have a placebo arm in neuralgia patients. That is one major problem in designing research studies with neuralgia. So because of these constraints, not very many studies have happened wherein we can have absolute evidence that one particular molecule or one particular method is good and bad. Time tested is carbamazepine. Apart from that, we have oxycarbazepine. Oxycarbazepine is a molecule similar to carbamazepine. Only advantage is the side effects are lesser. Baclofen, as you know, is a muscle relaxant. It is useful as an adjunct in neuralgia patients, especially when they are having systemic multiple sclerosis. Then gabapentin is more a neuropathic pain, not no evidence that single-use gabapentin can manage neuralgia completely. Lamotrigine again is not a very suitable method for managing trigeminal neuralgia. But in multi-drug therapies, a combination of these molecules are used. I also use them sometimes with mixed responses. There is no definitive, when I add gabapentin or lamotrigine, it is not as definitive that what results I expect happen. So the responses are mixed. But by far, carbamazepine is a promising molecule in terms of gaining patient confidence in managing the pain symptoms. Now, my method of managing patients, initially primary I use carbamazepine, and I use a supportive treatment of proprietary Ayurvedic medicine. These are herbs infused in gingerly oil. It needs to be applied onto the scalp once a day, 2 to 3 drops. Progressively, what happens over a period of 6 to 8 months, carbamazepine becomes my supportive treatment. Initially, when I start with carbamazepine, start with 200, I've reached up to 600 to 800 for pain management. But over a period of 6 to 8 months, when the pain episodes or intensities start to reduce, I taper the dose down and then make the patients apply the Ayurvedic medicine more frequently. With this, what I'm able to achieve is just 100 milligrams of extended spectrum, extended release molecule, carbamazepine is adequate to manage patients' pain. Now, whether the result I'm getting is because of this combination therapy or the patient is going into spontaneous remission is difficult to conclude. But when we look at the quality of life of the patient, this is definitely making a difference. And this is how I plan to manage my patients in future as well. Now, the next question that might come to your mind is, what is this Ayurvedic medicine? Can we also use it? Now here, this is a proprietary formulation of mine. And again, it becomes difficult for me to share the medicine or the formulation with you. But plain gingerly oil, the cooking grade gingerly oil, also has a medicinal property. If you start using gingerly oil, plain gingerly oil, that is also helpful. Many of the referring practitioners who generally refer patients to me, when I have suggested them to use this gingerly oil, they have reported that it is helping the patients even without, there is no herb infused into it. So you can also try this. Just 2 or 3 drops of cooking grade gingerly oil to be applied over the scalp, 2 to 3 drops once a day, along with your regular medicines. So when the patient is responding, you can gradually taper down the allopathic medicine or carbamazepine. And that's the end of today's talk. you have any questions for me, please let me know.
Thank you, sir. That was a very informative talk. Thank you for addressing the questions also. We have a few more questions. Are there any non-pharmacological management for trigeminal neuralgia?
Okay, see, cognitive behavioral therapies is one method which you can try. Then meditation, and for people who have faith in the concept of Veda mantras and other beliefs, the effects of mantras can make a difference to us. Gayatri mantra recited in the Samagana style has an immense potential in regulating any disease processes. It's a simple 4 or 5 line mantra which can be recited on a daily basis. You need to get initiated through a guru and then practice it for a short duration on a daily basis. This will definitely help in managing your general health as well as neuralgia conditions. And apart from this, there is another mantra called as Pantama. Yeah, even the recitation of this mantra has helped many of the patients with neuralgia to reduce the dosage. I'm not telling this mantra recitation is going to cure the patients from pain, but then the dependency on the medicine reduces. Now again here we can't do case control studies to say that mantras have been effective because we cannot have a placebo arm in the trials. But then when we look at the holistic method of approach and then the belief system and the faith in these traditions what we have, and we are looking at improving quality of life of these patients. So definitely there is no harm in trying these methods. And one of the easiest methods if you are looking at is to use cooking grade gingerly oil, a couple of drops on the scalp.
So we have one more question. How often does remission occur in trigeminal neuralgia patients and how long does it last?
Okay, now this is a very difficult question to answer because there is variation from patient to patient. Now from my experience, when I look at the pain patterns, I've been trying to associate these pain patterns with the moon phase. Okay, I don't have definitive answers, but then there is changes in the moon phase also have the effect on the intensity of pain. Okay, and when we are talking about remission, when not only from my experience, from the experience of people who generally handled neuralgia patients, during monsoon season or during winter season, the pain episodes are more. And after that, the episodes die down. So like this, remission is very difficult to predict. And it is not that we can say, okay, this group of patients, it is going to go into remission in 2 months or 1 month. It varies from patient to patient. So it is very difficult to say when the patient is going into remission. But natural remission is always a possibility in these cases.
There's one more question. How is Botox useful in trigeminal neuralgia?
Okay, see, generally when we look at neuralgia, we have these trigger zones. Okay, so there is concept of this channelopathy, which the hypothesis is coming up. Probably if you are using Botox in these areas, you're probably killing those channels or something like that. But I don't have definitive answers on this because I've not tried this. And what limited knowledge I have is from literature review.
Dr. Megha has asked, what is the difference between trigeminal neuralgia and neuropathic?
Okay, see, neuralgia is the electrical imbalance that is happening in a nerve, whereas neuropathic pain could be because of deafferation or demyelination. It could be because of trauma or compression. So they're sort of overlapping, but then the differences are Here there is electrical activity like in idiopathic neuralgia, whereas neuropathic pains, it could be because of compression injuries or demyelination injuries.
Thank you, sir. Those are all the questions which were asked. As a token of our appreciation, we would like to present Dr. Suhas with a certificate. Thank you,
Thank
sir.
you. Certificate accepted. Virtual certificate.
I now request Dr. Shruti Hegde, coordinator of the Orofacial Pain Clinic, to deliver the vote of thanks.
It's my privilege to propose the vote of thanks and acknowledge the contributions of those who worked hard to make this symposium on orofacial pain successful and a great learning experience. On behalf of Department of Oral Medicine and Radiology, ABSMIDS Memorial Institute of Dental Sciences, Nitte Almighty God for making today's event a grand success. Our heartfelt gratitude to the management of Nitte deemed to be university for providing us the opportunity and the conducting today's program on such a grand scale. A special thanks to Professor Dr. Mitra Hegde guiding us. Thanks to the resource person, Dr. Ruchika Sood, who spent her busiest time to share her knowledge and vast experience in the field of orofacial pain with us. Today, we had the opportunity to hear your lecture, madam, and this has definitely helped us in enriching our knowledge. Thanks to Dr. Suhas S. for being the resource person and sparing your valuable time to enlighten us with your thorough knowledge and expertise in the field of orofacial pain. Hearing you today. I thank the director and faculty of Staff Development Center and IT department of Nitte deemed to be university for providing us for
Thank you, ma'am.
I would like to thank Dr. Ash Babu, former HOD and professor, for his valuable input for the program. I'm very grateful to Dr. Ananya Madiyal for being Master of Ceremony for today's program and helping us to organize the same. I express my deep sense of appreciation to all faculty of Department of Oral Medicine and Radiology, Dr. Renita Castellino, Dr. Kumuda Rao, Dr. Supriya Bhatt, Dr. Sonika Achali, and postgraduates of the department, Dr. Faisal, Dr. Vaibhav, Dr. Dipti, and Dr. Anand for their support. Finally, I would like to thank all the delegates. Without you, this program would not have taken place. We
Thank you, ma'am. I hope you have all had a very rich learning experience. The link for the feedback form will be added in the chat box as well as the email. I request all delegates to fill the feedback form in order to receive the certificate. Hope you have a good day. Thank you.
From across India and abroad.